online certification. I am this entire scientific program has been curated very nicely with lots of inputs from Dr. Madhuri Patil. She's actually worked, I mean, a huge task to put up a 3 days program. And along with Dr. Fassi Lewis, Dr. Sarita Bhalerao, myself, and the entire team. This huge task was given to us by Dr. Parul Kotrawala. Thank you so much for that. And I hope that this program goes well, and people, everybody is happy with this whole scientific program. So to begin with, we will have the first the can you place the CVs of everyone here, and then we start with the prayer meeting, the prayer, and then we will start with the program. So today is the first day of the program, and for the day we have chief guest Dr. Jaideep Tang sir, the President FOGSI, and Dr. Madhuri Patel ma'am, Secretary General FOGSI. So let us have the prayers and then we start with the program.
असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्युर्मामृतं गमय ॐ शान्ति शान्ति शान्तिः.
So thank you very much. And we have here our President. I think Dr. Jaideep Tank will be joining in a bit. We have Dr. Parul Kotrawala here. We have Dr. Madhuri Patel ma'am. We have Sheila Mane ma'am here. We have Dr. Parag Binewale and Charmila, the series there. Then, of course, Dr. Madhuri Patil, Dr. Fassi will be joining in some time. And I have also been guided and ably supported by three very nice conveners that we have, the coordinators. Dr. Srishti, she's already joined for today. Dr. Samita will be coordinating for tomorrow, and Dr. Sandhya Meshram will be doing the day after. So we gave one day each to each of the coordinators. So shall we start with the CV of our chief guest first?
Meenu, ask Dr. Parul to give his welcome address first, and then we go ahead with the guests.
Yes. Yeah. So the first welcome address will be the chairman of ICOG, Dr. Parul Kotlawala, a good friend. I have known him for like so many years. He's an excellent endoscopic surgeon, consultant gynecologist, professor, head of the department at Sai Institute of Medical Sciences, Ahmedabad. Also at Kotlawala Women's Clinic, Ahmedabad. He's a senior consultant at Zaitas Hospital. He's a chairman of ICOG, vice president ISOPAV. He's also the chairman of the Education Committee, SAFOG, India coordinator for European Surgical Academy, India coordinator again for International Adhesion Society. I didn't know there was a society for the International Adhesion Society. Then Vice President FOGSI, President SOGOG, that is the state organization of the state of Gujarat. He has been the president of Ahmedabad OBGY Society, and also he was the chairperson for the scientific committee AICU 2017. All very pleasing personality, always smiling, very cool. So whatever, even if whatever is going on, he's very cool. Yes, go on, go ahead, do it, no problem. So thank you very much for being there for this program and guiding us through the entire 3 days scientific deliberations. Over to you, Dr. Parul, sir. Thank you.
Thank you, Dr. Meenu. Well, two things I need to correct. You are saying that I am always smiling. You ask my daughters, and they say you never smile when you are being clicked for a photograph. Word on International Adhesion Society, since you said, it is said that whoever finds the cure of additions will become next Bill Gates. Such is the potential of addition medicine, and unfortunately, we have none as of today. Infertility is, I believe, if you ask resident doctors while they are getting specialized in OBGYN, 70% of them, when you ask them what would you like to be or what would you pursue as your interest, they would say infertility. It is very interesting that such a halo is there around fertility practice. And I'm sure that this program would be of great help to all these people. Of course, as the days go by, more and more senior people come for pregnancy. They get married late and then they decide again pregnancy even later. And so the challenges multiply for us to take care of them. So I wish you a very good program over next 3 days. And see, this is one of the most sought after program of ICOG, and already I see 200 plus online people joining it. So I'm sure that you, along with Madhuri and the entire team, will do justice to this. All the best. Thank you.
Thank you, Parul sir, for these kind words and words of wisdom by you. And I agree with you that everybody is trying to learn and get into infertility, and this program is really going to be a boost to their infertility practice. Uh, so, um, uh, so we have Dr. Madhuri Patel here, and Dr. Jaideep Tank will be joining in a bit. Madhuri ma'am, welcome and thank you. So Madhuri ma'am is the Secretary General of FOGSI. She is the Editor-in-Chief of Journal of OBGY Society of India, Jogi Journal, and she just now said that she works at the journal after 12 in the night. So we all can understand how much hard work you must be putting in to get so many positions in your kitty for yourself. The Joint Secretary FOGSI 2009.
Thank you, Dr. Meenu. Thank you, Dr. Meenu, for your kind words. So, respected our President, Dr. Jaideep Tan, and today's chief guest, Dr. Parul Kotrawala, our ICOG chairperson, doing excellent work as a chairperson. Dr. Sheila Mane, vice chairperson of ICOG, and I'm happy to share she has come over here in FOGSI office where I am also there to understand, to know what she will do in her election. I'm in the ICOG chairperson. So I'm very, very happy. Of course, the courses are going on. So I'm happy that she's also planning so much in advance. So I'm happy to see that. Then, of course, my dear friend, Dr. Parag Biniwale, we have worked together when I was a joint secretary, and we had a very great time in academic as well as enjoying the all the CMEs and all. And Dr. Sarita Balirao, Secretary ICOG, very sincere and very hardworking. Today's the series conveners, I have said, Dr. Parag Biniwala, Chairperson elect ICOG, Dr. Charmila, Vice President FOGSI and ICOG GCA, conveners Dr. Meenu Agarwal, Dr. Madhuri Patil, and Dr. Faisal Lewis. And let me say that Meenu has really worked hard for this course, and she has been calling up every time that you have to join. So Meenu, thank you for that, those reminders. And coordinator Dr. Srishti, Dr. Samida, Dr. Sandhya, and I can see that. So I can see everybody, yeah. And then we have, I have seen Dr. Manish over here, yeah, Ajay, all are there, whichever I'm seeing in my desktop, and rest of the thing, all dear friends, very good evening to all of you.
Good evening. Good
All of
evening.
us are aware that ICOG is the academic wing of FOGSI and doing excellent work as far as the college activities are concerned. I must say that there are 6-month training courses and 1-year training courses in ICOG. They are also in a demand because the teachers, the centers which they are conducting, they are really teaching them very well, and that's why they are in demand. Of course, then we have these certificate courses, and Dr. Parul has started with his team. And infertility, as Dr. Parul has mentioned, is a very common condition in nowadays because of the late marriage and late conception. And not only the infertility specialist, but also as a general gynecologist, we should be aware that how far we can go and how much justice we can do. And once they fall pregnant, they are really, really happy to know that, and they come and tell us that because of you, I'm pregnant and I'm going to have a child. So that is a very, very rewarding things we have. And of course, ICOG CMEs are going on very well. Just now I talked to Dr. Parul and everybody that we were there in Muzaffarpur for the ICOG, FOGSI ICOG CME. And it was a very, very big crowd we had, and we really appreciate it. So with this, I'm not going to take much time. I'm just congratulating all the organizers and wishing you best luck, and you should continue these certificate courses. You can see you have already joined and you have more than 600 registration. So it shows that how demanding these certificate courses are. So congratulate all of you, and thank you once again for giving me this opportunity. Thank you.
Thank you, Madhuri ma'am, for these kind words and the blessings for the course. Can I have Sheila Mane ma'am to say a few words? And Dr. Jaideep Tank, whenever he joins, we will ask him to speak.
Yeah,
Because
I think, thank you. Thank you, Meenu.
Thank you, ma'am.
I think we'll not waste time in introduction. All of us, we know each other.
Give me 1 minute, madam, to introduce you, and then you speak, ma'am. Dr. Sheila Mane, ma'am, most humble, and she said don't introduce. So she is the ICOG Vice Chairperson 2024, and as Madhuri ma'am said, she's so hardworking and so pre-planned. Right now she's planning as to how to go ahead for the program in the coming year. So very, very happy to have you, Vice
Thank you. Yeah.
Sheila Mane ma'am. So thank you very much for joining, ma'am. Please.
Yeah. Yeah, thank you. And I think as everybody has already addressed most of the things, I must tell you, very well framed. And today's program is very important basics. I wish postgraduates join today, the general gynecologists, because these are these today's topics are very useful for a general gynecologist, because at this level, we are treating the infertility, and of course the postgraduates, because most of the time the postgraduates are not exposed to infertility topics so well than the routine obs and gynae. So I must congratulate Dr. Meenu, Dr. Madhuri Patil, and Dr. FOGSI for coming out with this excellent program. And thank you for giving me this opportunity. And I wish all the best for your 3 days program. And I'll be there again tomorrow joining to welcome you all on second day. And thank you.
Thank you, Sheila ma'am. Can I have Dr. Parag Binewale, Chairperson-elect ICOG?
Meenu, don't waste time in introducing. We are already 5 minutes behind the schedule, so I think let's get on with the business. And there are so many people writing about pre-test, so I think it's time that we start our program, right? And we'll start with the pre-test right away.
Okay, so thank you, Parag. Thank you for your short and sweet message. So this course now we will be starting. So we are giving a pre-test to all the delegates. So you will get the link. So you just go on the link, and when you click on the link, you will get uh, the pre-test MCQ test. So you have to see, just fill up the pre-test, and then once we finish the course, the day, then you will again be given the same test, and we will see how much you have improved after listening to the entire day scientific deliberations. So, can you post the pre-test link, Nilima?
Yes, Vedika, please post the link in chat box and put on the timer.
Nilima, please make sure that everybody else is muted because there are so many disturbances going on simultaneously.
Dr. Panchal joined. Srishti, can you please check?
Yes, ma'am.
Has
Good.
Dr. Panchal joined? Can you please check?
Yes, ma'am.
So we have today Dr. Sonal Panchal's first lecture, followed by Dr. Rekha Jirge. Then Dr. Madhuri Patil will be talking on semen analysis. Then we have Dr. Charmila on IUI patient selection. followed by ovulation induction by Dr. Rakhi Singh, and then monitoring cycles I will be taking. After that, we will have a case-based discussion which is a panel discussion, which will be moderated by Dr. Sujata Kar. There are good 5 panelists for that: Dr. Jayarani Kamraj, Dr. Kundan Ingle, Dr. Dipti Gupta, Dr. Neena Malhotra, and Dr. Tejas Gundevar, followed by post-test. So this is the entire day's program. And today's is all basics. So it is, I mean, I really, Dr. Madhuri Patil, again, I'm saying that the way you have designed the program, day 1, only basics, day 2, little advanced, and day 3 is all advanced, and also the ART law and everything, so that people who are already practicing will know what to do and what not to do. So we have very, very good speakers on all the 3 days. We have Dr. R.G. Patel speaking on the ART bill, Dr. Naina Patel speaking on surrogacy, and if you look at all the 3 days program, Dr. Sunil Jindal will be talking on the paternal aging, which is again coming up in a big way in infertility. Dr. Nalini Mahajan will be talking on PRP. Dr. Rishma Dhillon Pai will be talking on the uterine factors. Again, implantation failures, a big topic to cover. Dr. and Dr. Manish Pankar. So they will be talking on the recurrent implantation failures. We again have adjuvants in ART, case-based discussion. Everything is very clinical. So there are cases, the cases will be put, and what is the solution. And so even delegates can think, and whatever questions you have, please put it in the chat box. We try and take up all the questions, question answers that we can.
According to the Apple bounce code.
And everyone keep yourself on mute. Sorry. So, yeah, so everyone, please keep yourself on mute. And we have very nice way of Dr. Madhuri Patil has designed the whole program in a very, very nice way. First day is only basics. Day 2, then we progress to little advanced, and day 3 is again more advanced. So, some topics on ART bill, everybody wants to know ART law, surrogacy new bill, all that will be covered by Dr. R.G. Patel, Dr. Naina Patel. So these are there. In recurrent implantation failure, again, very difficult patients sometimes to manage. Again, good speakers that we have and good topics. We have Dr. Rishma Dhillonpai, Dr. Priya Kanan, and Dr. Manish Bankar talking on the uterus, the embryo, the immunological causes for these. So if there is some noise, so I think I will not talk, so that you can fill up the Google form for the pre-test, and then we have 5 minutes to go.
I did not get the link for pre-test. Please ensure.
In the chat box. Just go on the chat box. The link is in the chat box, madam. Have you got it? Yeah, Sonal ma'am, I can see you. You're mute.
Yeah, I was not allowed to unmute myself. Now it's right. But today my net connection is very unstable. So that is the reason I've sent the recording. I'm here only. I will answer all the questions, but that is the reason I have sent a recording.
As well. Okay, that is great. That is very good. Mhm.
I think Nilima, once more you have to share the link.
Yes, Vedika, please.
Okay, man.
The time is over for the pre-test and many people are asking about the link. It is in the chat box. So you can just copy that link from the chat box and answer the questions. All right. So we start with our first session, session 1, basic that needs to be known. So we have the chairpersons for this session, Dr. Supriya Jaiswal. Can I have her CV, please? Yes. So, Dr. Supriya Jaiswal, very, very dynamic. She is the Vice President of Patna OBGY Society, Chairperson of Adolescent Health Committee, FOGSI. She is the Joint Secretary, SOVSI Bihar and Jharkhand Chapter, Chief Consultant at SMS Hospital, Patna. She is the Executive Member of ISOPAB, ISAR, IAGE, and she has been trained in colposcopy, awarded many awards and certificates, and she's also held the post of Joint Secretary, Clinical Secretary, Executive Committee
Thank
member
you, madam. Thank you.
of BGY Society. So you represent Patna for us. And then we have our second chairperson, Dr. Pratibha Singh. Again, very dynamic, good, great personality. Always a pleasure to talk to you, Pratibha ma'am. She's a consultant laparoscopic gynecologist and an IVF consultant. She is the director of Healing Touch Hospital in Bhagalpur. She's the chairperson of International Academic Committee FOGSI, and she's also the chairperson of Fertility and Aging Committee of Indian Menopause Society 2023-24, president of Bhagalpur Menopause Society. She has had diploma in advanced gynec laparoscopy from Germany. She is the founder secretary of FOGSI Bihar and Jharkhand chapter. She has presented many papers, contributed many chapters in various books and journals, and also presented many times in conferences. She's the honorary professor of IMA in 2022. She's had the recipient of National Best Teacher Award by IMA and many other awards to her credit. So, Madam Dr. Pratibha Singh, and we have our pleasant Dr. Cool again, Dr. Ajay Mane here, a good friend and a second joint secretary of FOGS, and he is the vice president FOGSI. He is also a member of National Inspection and Monitoring Committee, PCPNDT wing, Government of India. He's a medical legal consultant. I remember when, he has a huge fan following because he does a lot of medical legal consultancy for a lot of doctors. He's chairperson for official FOGS website, Sexual Medicine Committee, Adolescent Health Education Committee. He's the past president of Aurangabad OBGYN Society and health advisor to Sports Authority and a charter president of Rotary Club. So thank you, Dr. Ajay Mane sir, for joining. Then we have Dr. Varsha Baste, ma'am. Is she here? I can't see her. But again, Dr.
No, excuse me, these people need to be unmuted. Dr. Varsha Baste, Dr. Pratibha Singh, Dr. Ajay Mane, they are all unable to unmute themselves.
Yes, madam. Yes.
Okay.
So, Dr. Sapre. So, Dr. Varsha Baste.
Hello, I'm here.
Yes, yes, yes. So, a great fashionista, I should say. A very a lovely person. She's from Nasik, has been practicing for over 30 years. She also has a center of anti-aging. I think she herself is also taking those anti-aging because the same for so many years. She's had the first ICSI PGD baby in north of Maharashtra, past president of OBGYN Society in Nasik, chairperson of FOGSI International Academic Exchange Committee. She's been the awardee for the prestigious Anandibai Joshi Award and organized many national, international conferences and many publications. So we have all these four chairpersons, and you can start with the sessions. Please take over. Thank you very much.
Thank you, Dr. Meenu. I'll start because I need to go in 5 minutes. So I'm so sorry, my co-chairpersons. Respected Jaydeep, thanks sir, Parul sir, Madhuri madam, Sheila ma'am, and Sarita ma'am, and my lovely brother, Dr. Parag, and my co-VP, Dr. Sharmila, and our own Dr. Meenu from Pune. Best luck, Meenu, for your endeavor in FOGSI, and I know you are there 100%. Dr. Madhuri Patil ma'am, Dr. Fesi, Dr. Srishti ji, to whom I troubled a lot since morning, Dr. Samida, and Dr. Sandhya Mishra. Today's first session will be on baseline ultrasound, do ovarian reserve test, correlate with the ovarian response, and semen analysis. And my co-chairpersons are Supriya ji, Dr. Pratibha ji, and Varsha Baste madam, just now introduced by Dr. Meenuni. So I invite the first speaker, Dr. Sonal Panchal. She is a consultant, Dr. Nagari Institute of. I lost the Sonal ma'am's CV. Actually, she don't need a CV. Can you show that CV, please? Hello.
Sonal madam doesn't need any introduction.
Yeah, I
No
know
CV.
that. I know that. But for the sake of all audience, we must tell some of the achievements. She is a very great personality. She has got PhD in ultrasound in gynec and infertility. She is a master ultrasound in OBGYN and University School of Medical Ultrasound. She is a professor, Government International University, National Academic Director, and Donald School India, Director, Center of Excellence, and Donald Inter-University School of Medical Ultrasound, Ahmedabad, India. She's a member of National Advisory Board for the International Journal of Infertility and Fetal Medicine, JP Publications, She is the reviewer of Journal of Human Reproductive Sciences. Published 45 papers, maybe more than that, but it must be an old CV. 45 papers in national and international journals. She has delivered more than 1,000 lectures. They have given 800. I don't believe this. Contributed in and authored several books, more than 120 chapters, and so many of the things. So I welcome, and I am honored to be her chairperson today. So I welcome Sonal ma'am, and I request you to please continue with your topic.
Thank you, sir, for your very kind words.
Thank you, ma'am. Thank you, madam. Please continue.
I will request the team to please connect to my lecture that I've sent recorded, because my net connection is today not very reliable. So please.
Hello, friends. Good morning. And today I'm going to talk about the baseline ultrasound. How is it important in infertility? Of course, the time is very short, and I will just give you an overview. What do we mean by baseline scan? A scan that is done before planning the treatment, not necessarily always done on day 2, but people these days prefer to do it on day 2. I want to make it clear here that when it is done on day 2, that is when there is a high possibility of missing the uterine abnormalities. It's good for adnexa and for assessing the ovarian reserve and response. The purpose, of course, is to find out any pathologies of the reproductive organs. If there are some lesions, to decide whether they're physiological or pathological. If they're pathological, they are concurrent with the cycle or not. And if they are pathological and not concurrent with the cycle, will they come in the way of treatment or not? And do they require a prior treatment? We will divide the discussion into uterine, ovarian, tubal pathologies, tubal patencies, and ovarian reserve and response. Starting with the uterus, which is otherwise a mid-sagittal organ, midline organ, and is always seen in a mid-sagittal plane. If it is not in the midline and if it is deviated, think about either duplication abnormalities, or think about the unicornuate uterus, or a pathology which is pushing or pulling the uterus onto one side, which may involve the adnexa, or there may be asymmetrical involvement of the uterus in any of the intrauterine lesions like fibroid or adenomyosis. Duplication abnormalities are to be suspected when on the transverse section, as you move towards the fundus of the uterus, you would see division of the endometrial cavity. There may or may not be dimple on the serosal fundus, and depending on that, it would be either a bicornuate or a septate uterus. 3D is diagnostic. 3D shows peripheral, so serosal contour as well as endometrial contour, and both in the coronal section, and therefore is now used as a gold standard for differentiation of all the duplication abnormalities as well as for the diagnosis of the T-shaped uteri. And the literature study has proved it is almost as reliable as MRI and as reliable as the combination of hysteroscopy and the laparoscopy. Especially when it comes to T-shaped uterus. Any narrow uterus is not a T-shaped uterus, which needs to be understood. And only if there is a lateral wall thickening as compared to the myometrial wall thickening, only then we call it a T-shaped uterus. And every T-shaped uterus has to have a normal uterus-cervical ratio. Altered uterus-cervical ratio is in favor of a hypoplastic uterus. Coming to endometrial pathologies, irregularity of the junctional zone, thickened endometrium even in the early proliferative phase, and increased vascularity in the early proliferative phase are the signs of acute endometritis. And it interferes with the implantation, as we all know. So does the chronic endometritis too. Persistently thin endometrium, irregular junctional zone, fluid in the endometrial cavity with hyperechogenicity of the internal margin in the mid-proliferative phase, scarring or narrowing of the endometrial cavity are all the signs of chronic endometritis, especially when you see vertical orientation of the interstitial part of the tube. That's when tuberculosis is suspected. Apart from that, tuberculosis may also have an irregular endometrium with or without calcification. Calcification may be seen in the endometrium, in the endomyojunction. It may be seen in the myometrium also at times. And there may be also micropolyposis. All this suggests possibility of tuberculosis. Polyp, a solid lesion in the endometrium with a single feeder vessel, If it is adenomyomatous in origin, the the feeder vessel may give multiple branches. 3D is diagnostic. It helps to differentiate between a polyp from a hyperplasia. And so 2D Doppler and 3D altogether give you complete idea about the polyp. But when it is a polyp, when it is any endometrial lesion, that is when it is always good to put in some saline, do a saline infusion, no hystero, and that would beautifully show the endometrial lesions. And you can see the comparison of the ultrasound picture with that of the hysteroscopy in both the images. Hyperplasia, which may be of a stromal predominance or a glandular predominance. It's very important to remember here that any thickening is not called hyperplasia. It is more of a morphological abnormality which needs to be identified. So many a times you may find an endometrium which is already 15, 16, 17 millimeters thick in the pre-secretory phase or in the pre-ovulatory phase. But if the morphology is normal, this is normal. But even if it is only 10 millimeters, but the morphology is abnormal, mildly hyperechoic with multiple anechoic areas, is suggestive of hyperplasia. When it is predominantly stromal, that is when you will see multiple tiny anechoic areas which are almost equal in size, and it is solid tissue which is, or echogenic tissue which is more thin. Or when it is glandular predominance, you will see multiple anechoic areas of various sizes. Glandular is usually less vascular as compared to the stromal. And endomere junction is intact in both. Coming to the synechiae, persistently thin endometrium, only a sign on the 2D ultrasound. Sometimes you may see multiple tiny fluid locules. It would be best to do a 3D and preferably with a saline infusion that would show you beautiful synechiae. Saline infusion is done with by just injecting 3 to 5 ml of normal saline. Whenever there is a calcification seen, that is when it is very essential to always do a 3D and find out the not only the exact thickness of the calcified area, but also to identify exact location, whether it is truly in the subendometrium or in the endometrium. And that would make difference in the possibility of implantation. Coming to adenomyosis, it impairs implantation and leads to subfertility because of mechanical factors, because of genetic factors, vascularity impairment, and also defect in the peristalsis because of the junctional zone involvement. Heterogeneous myometrium with obliteration of the junctional zone, as you are seeing here, you may have multiple tiny myometrial cysts, hyperechoic dots and lines, and typical fan shadows. The junctional zone, apart from being obliterated by the endometrial tissue, as seen in the previous image, it may also sometimes be irregular, sometimes may be inaccessible. You may have hyperechoic islands of endometrium, or you may also have hyperechoic dots and lines of endometrium. So these are all the 2D signs of endometriosis. Junctional zone evaluation is very important, which is made possible by 3D ultrasound. You can evaluate the difference in the thickness, and that makes it comparable to MRI. Looking at the Doppler, you would see translutional vessels. They disregard the margins of the lesion, they run through and through. They may have a larger diameter than the diameter of the normal spiral vessels, and they're chaotically arranged, not the typical spiral vessel arrangement parallel to each other and perpendicular to the endometrium. Apart from that, adenomyosis may also sometimes show what is called question mark sign, a reverse curvature of the uterus. Beyond the mid half of the body or towards the fundal side. Fibroids, well-defined, round, oval, lobulated lesions, hypoechoic usually and homogeneous, but when they get degenerated, show heterogeneous echogenicity, which may be in the form of hyperechogenicity, maybe just calcified ream, or maybe cystic degeneration. The type of degeneration, myxoid or red degeneration, cannot be histopathologically identified based on ultrasound alone. But it is important to remember that whatever is the fibroid degeneration, whenever there is a fibroid, there's always a peripheral vascularity. In degeneration, there would be internal vascularity. The vessels are limited by the peripheral vascular ring, but presence of internal vascularity and heterogeneous echogenicity are the signs which tell us degeneration of the fibroid. 3D is especially useful for the fibroids which are close to the endometrium to find out how much is the invasion or compromise of the endometrial cavity. And we know that the fibroids can be can be of various penetration. They may penetrate towards the endometrium, they may penetrate towards the serosa. Of course, they arise from the myometrium. So myometrium is its home location, but apart from that, it may sometimes protrude right inside the endometrium, called subendometrial fibroids. It may be large enough to touch the endometrium on one side and the serosa on the other side, or it may be also sometimes subserosal, as you are seeing here, which may just touch the serosa, not touch the endometrium. So these are all different, and here there are multiple fibroids. In fact, so fibroid can be of various can be into various locations, upper, lower, or the middle third of the uterus, right, left uterine wall, and a fundus or anterior posterior wall, and everything needs to be reported in detail when you describe a fibroid. This is just to show you 3D helps in exact delineation of the fibroid. Not only that, exact amount of compromise of the endometrium can be identified, and the correct distance from the endometrium also can be measured in cases of intramural fibroids. The reporting of the fibroid is very essential. Mention the number as coming in the images. Size must be described as into three different by three different measurements, three longest orthogonal measurements. Location is to be completely perfectly described: upper, middle, lower third, anterior posterior wall, right, left lateral wall, or the fundus. The penetration needs to be described. You need to also describe the ecogenicity, the reams, the shape, the distance from the endometrium, and also the distance from the serosa, so that the operative plan can be well done. And preferably, one must give a complete fibroid mapping by pencil diagram in the mid-sagittal transverse and the coronal planes. IUCDs may be displaced as seen here, or may be forgotten, and that they may present as infertility. So IUCDs can be seen and identified beautifully on ultrasound. 3Ds may be even better, because then you don't have to take any measurements. 3D does also show not only the displacement, how much is the displacement, and whether there is any myometrial invasion. Scar assessment, scars are very common, but when there is no fluid collection or minimal fluid collection, or they may be hyperechoic with a posterior shadowing, it may appear hyperechoic also. Sometimes these are all healthy scars, but when there is a fluid collection, triangular in shape with a base at the endometrium, and involving more than half of the thickness of the myometrial, thickness, that's when it is more, we report it as ischemosal. These days are quite commonly seen, and they are of concern because of the risk of scar pregnancy, or maybe because of the fluid persistently flowing inside the endometrial cavity, the infective fluid, and not allowing the implantation to occur. In all cases of ischemosal, therefore, it is essential to look at the possibility of fluid in the endometrial cavity and its persistence. At neck cell lesions, anechoic cystic lesion with no septa, no solid projections, correlated always with the phase of the cycle. In the proliferative phase, think of an active follicle. Put on a Doppler. Follicles as small as 10, 11, 12 millimeters. Also, if they are active, they will show peripheral vascularity. If the shape of the follicle appears irregular and there's minimal vascularity, it may be a residual follicular cyst. Hyperechoic walls with low level echogenicities and scanty high resistance flow would tell you it is an LUF, whereas residual follicle is round or oval in shape, seen in early proliferative phase, and may show scanty peripheral vascularity with a high resistance flow. So these are the differentials, and always think of physiological reasons first. Whereas if it is a cystic lesion with hemorrhagic echogenicities inside, the three possibilities in the ovaries would be either a corpus luteum, or maybe a hemorrhagic cyst, or maybe a residual corpus luteum, if it is a residual corpus luteum, which may be seen in the early proliferative phase. So this lesion, if you're seeing in the secretory phase, naturally first think of a corpus luteum. Corpus luteum will always present with a beautiful ring of color, with a low resistance flow. Hemorrhagic cyst is nothing but a residual corpus luteum which has stopped functioning but is not disappeared anatomically, and therefore it does not have any blood flow, not functionally active. Whereas residual corpus luteum, if it is regressing, will show a high resistance flow. So these two are seen. This is seen in the secretory phase. These two are seen in the proliferative phase. If you see a similar lesion in the secretory phase, it is an inadequacy of the corpus luteum. Corpus luteum, though it must be remembered, may have any of the 2D appearances, may be also isoechoic at times. Hemorrhagic cyst we have already talked about. Endometriomas, typically described as ground glass appearance, but not more than 60%, 70% of the endometriomas may have that. Hyperechoic flakes that you see in the wall, vertical fluid level with anechoic layer anteriorly and ecogenic layer posteriorly. Acoustic streaming sign because of thick fluid, and short course vessels, as you are seeing here. Vessels come and approach the wall but do not run across, with a bird's nest sign on the 3D power Doppler are the diagnostic sign. In all cases with relevant complaints, one must check for endometriosis, trace the entire anterior muscularis of the bowel right up to the sigmoid colon, which is at the level of the fundus of the uterus, and any lesion which is hypoechoic, irregular in shape, D-shapes the anterior muscularis with the hyperechoic margins and hyperechoic outer margins and hyperechoic flakes, pain on probe pressure. On transverse section appears like a signet ring, unless proved, is a patch of endometriosis on the bowel. You can see here very beautifully coming up. So that is a patch of endometriosis. Endometriosis may also be seen in the uterosacral ligament, or superficial endometriosis can also be diagnosed on the peritoneal surfaces. Dermoids, hyperechoic dots, lines, tooth-like shadows with posterior shadowing, vertical fluid level with hyperechoic sebaceous material and fluid posteriorly, hyperechoic blades with posterior shadowing. Tip of the iceberg sign, where there is a hyperechoic ball with posterior margin not identified. It is a fat ball. You may see a hair ball, multiple hair balls. There are all the signs, 2D signs of dermoid, and dermoids are typically not vascular. There may be fluid collections with septa with lattice-like pattern, sometimes floating cystic lesions, which may be tuberculosis when it is suspected. Also look at the ovary. Ovary may show hyperechoic dots, ovarian calcinosis, and it shows hyperechogenicity of the periphery of the small antral follicles. Without any vascularity. So vascularity is unexplained. Unexplained hypovascularity is one of the typical signs of tuberculosis of the ovary, whether it is a stimulated or a non-stimulated ovary. Paraovarian cyst, always seen outside the ovary, easily movable from the ovary on the sliding organ sign, and has no vascularity, no solid projections, no internal echogenicities as a rule. I will confirm the vicinity with the femoral end, and it may be a femoral cyst. If you can see the same, any cystic lesion in the adnexa extraovarian especially must be thought of hydrosalpinx. If it changes shape, if it shows changes shape on rotation of the probe, if it shows incomplete septa, even if it doesn't become tubular, it can be a hydrosalpinx. It may or may not be adherent to the ovary, may or may not show thickened mucosal fold, depending on whether it is acute or chronic. And it is this thickened mucosal folds which appear like a cogwheel sign on the transverse section. But if it is a chronic, and that is more common in acute, if it is chronic, you would see limited diameter of the tube with hyperechoic walls. You may sometimes also see ovary adherent to it, tubo-ovarian masses. Sometimes ovary is not seen separately, and the margins of the ovary may not be identified, maybe tubo-ovarian abscess. Tubal patency assessment can be done with saline. You can, and 2D ultrasound, if you can see the fluid trickling, best sign. If you cannot see that, you may see fluid collection posterior to the ovary or posterior to the uterus. That may tell you one of the tubes is patent. No fluid spill, but you are seeing distension of the endometrial cavity, tells you it's a bilateral block. Color Doppler can be used here. put on the color box and inject saline into the endometrial cavity. The color blush surrounding the ovary tells you that it's a patent tube. Or you can see the entire tubal lumen by injecting air or any bubbles for that matter into the endometrial cavity, and you can see the spill of from the tube. You can see the entire tubal lumen as you saw there, the passage of the bubbles, or you can use a positive contrast and see the entire. This is sono view which is available from Breco, and you can see the entire tube, and you can also see the fimbrial end of the tube. This can be better seen on the 3D ultrasound, 3D power Doppler, or 3D ultrasound. Beautifully fimbrial details, entire tubal details, and uterus can be seen. And that is a pre-treatment scan. I know I have overshooted the time, so I'm not going to discuss the baseline scan, but you should be able to assess the ovarian reserve by antral follicle count and the ovarian volume, and the stromal flows are essential to decide the daily dose of the gonadotrophins. So pre-treatment scan is very essential before you start any infertility treatment. Thank you very much for your patient hearing.
Thank you, Sonal Madam, for your elaborate and crisp and up to the point presentation. We are always delighted, and I really like to attend each and every talk of yours. You have really told us in detail how to pretest this infertility patient just by sonography, and the person like you can diagnose any pinpoint diagnosis you can do only with sonography, because you are so learned and you are such a great teacher also. You have told us about how to diagnose the fibroid and adenomyosis and endometrioma, and the scar evaluation, and how to evaluate chronic endometritis, tuberculosis, adnexal masses like corpus luteum and endometrioma and whatnot, and everything you have told us in detail. And also the tubal factor evaluation. You have really given us very good insights by the wonderful videos. Thank you so much for your wonderful presentation. So
Thank
nice of you. And I'm so happy to co-chairperson for your talk. Thank you, ma'am.
Thank you very much, Dr. Baste, for those very, very kind words. You always have been a very close friend. Thanks again. Thanks.
Thank you, ma'am.
Sonal ma'am, I also want to tell you, like, wonderful presentation and so clear videos, the pictures, like anybody can understand the basics from your talk. Wonderful. I really wish I could have you in my place.
Thank you. Thank you. Yeah, thank you.
Thank you.
Mona will have to clone herself because everybody wants her.
Yes.
Yeah, I know.
Thank you, Dr. Meenu. Thank you.
Sonal Madam is on demand.
Thank
And
you.
Sonal Madam, your video says that there is no need of hysteroscopy. If you do very good ultrasound, 80 to 90% of anomaly you can diagnose, and you can have a virtual hysteroscopy with 3D vision. Thank you,
True,
madam.
true, very true.
Thank you.
The next,
I also have to go.
yeah,
For another webinar.
Dr. Pratibha Singh, madam, yeah. Will
Okay.
you?
Then I will leave. If you give me permission, I have to attend another webinar.
Sure. Thank you.
Thank you so much. Thank you, Meenu, and thank you, organizers, for giving me the opportunity.
Yeah, so Dr. Sonal, there are some people who are requesting a repeat of the last slides, but what we can do is we will probably, maybe they will get a link to again look at the presentation. So that will be nice. Thank you very much. So lots of very positive reviews from all the delegates who have joined for Dr. Sonal. Wonderful lecture, yeah. The next talk is by Dr. Padma Rekha. Can you share the slide? Yeah.
Madam Padma Rekha, madam is busy. Madhuri Patil will take the first.
No, madam is here.
No, she's come.
Madam is
Okay,
here.
okay.
Yes, Dr. Supriya, you can introduce Padma madam.
Very good evening to all of you, and it is a privilege for me to join this session. And thank you, the organizers, for having me here, Dr. Meenu and all the Dr. Parul, all have given me this opportunity. Thank you so much. Dr. Padma Rekha Jigre, she is Clinical Research Fellow in ART from University of Glasgow, Scientific Director of Sushrut as Assisted Conception Clinic and Shreyas Hospital, Kolhapur. She is also the founder director of Prismatic Research Foundation, completed her MSc Epidemiology in University of Edinburgh. Most recent publication, she has many latent genital tuberculosis adversely affects the ovarian reserve in infertile women, human reproduction 2018, then resuming assisted reproductive, that is COVID, during the COVID-19 pandemic. She has got many publications, and she also the chairperson Maharashtra chapter of ISAR, President-elect Fertility Preservation Society of India in 22-24, chairperson SIT Reproductive Endocrinology PCOS Society of India. Madam is immediate past editor-in-chief, Journal of Human Reproductive Sciences, responsible for getting the impact factor for the journal. She is a reviewer for Fertility, Sterility, Human Fertility, Cambridge. She is done from Cambridge, then Reproductive Biology and Endocrinology, JARG. Then recently appointed as a Deputy Editor of Fertility and Reproduction, Official Journal of Asia Pacific Initiative in Reproduction, and that is ASPIRE. So, a huge CV, and over to you, madam, for your presentation.
She's a true academician and a research person, totally research person. So just you co-host so you can share your screen.
Okay.
Yeah.
Good evening, everybody. Thank you, Dr. Meenu, for inviting me for this program. And it is so wonderful to see the enthusiasm that is there. Just looking at the response for the first talk. So I'm in between two stalwarts, Madhuri and Sonal. So I have to try and do bring in some interest to this topic you've allocated me to speak on. And Madhuri, I would like to acknowledge for all, for your help during all this confusion, because I wasn't sure whether I could be there in time or not for this talk, and she graciously had agreed to do her talk if I was delayed. Thank you, Madhuri. So I've been asked to speak on ovarian reserve tests, whether they correlate well with ovarian response, oocyte quality, and natural fertility. I think as clinicians, this is the most important question we need to answer for ourselves when we are dealing with female infertility, because unless we understand the limitations and the abilities of any of the tools we have in our hands to assess the fertility potential of an individual, we may not either we may not exploit it to its full benefit, or we may use it wrongly so that we may not be able to help our patients adequately. So we all know there has been a plethora of ovarian reserve tests available over a period of last few decades. So they could be biochemical, biological, biophysical, or histological. Over a period of time, the tests which have stood the test of time have been the biological one, that is chronological age, and some of the biochemical tests we use, that is FSH and AMH largely, and biophysical, that is antral follicle count. I know Dr. Sonal has spoken about various aspects of ultrasound and in what way it can be of help in diagnosing and managing infertility. But one of the most important tests we, with the help of ultrasound, we can do to assess the ovarian reserve is the antral follicle count. So when we look at the evidence that is available, background evidence that is available, we know that if we have to pinpoint and say about a particular one single test which can predict both oocyte quality and natural fecundity, it is the chronological age of an individual. AMH and AFC are both tools to directly assess the ovaries. as opposed to FSH, which is an indirect assessment. They both have similar sensitivity and specificity to predict ovarian response in IVF. This has to be taken in its entirety. So they, most of the time when we talk about ovarian response, we assume that everyone understands that is in the context of conventional IVF. So that is something which has to be understood. When we say there are good markers of ovarian response, it is in the context of conventional IVF. It's not in the context of a natural cycle IVF or modified, wherever we use minimal stimulation. So, or otherwise, oral ovulagens or IUI, or even for natural fecundability, it is not, we cannot correlate the findings or the evidence available from IVF or ICSI, that is conventional IVF or ICSI, to any of these other scenarios. So they are best predictors of ovarian response available today in the context of a conventional IVF. More studies have utilized AMH than AFC because AFC depends on certain important criteria, that is the type of the ultrasound machine that is being used, the ability of the individual to pay dedicated amount of time to assess the AFC, whereas now for AMH, automated assay platforms are available, and because of which there is to some extent international harmonization that has happened. That is, when I do the tests in Kolhapur, I can call up anybody anywhere in India or across the world. As long as I'm going by the specifications needed for those tests and I'm using an automated platform, the results can be compared across the world. So that is the advantage of AMH, and that is why it's being used more often than AFC. So now, as far as when we talk about oocyte quality, either it has to be pregnancy and live birth happening under natural or non-assisted conception, or it is through assessment in an IVF cycle. Whether these tests can be used effectively to assess the ovarian reserve in natural, those who are trying to conceive naturally, is uncertain at present. And let's just go through the evidence that is available. So now when we talk about whether ovarian reserve markers are good predictors of ovarian response, I think we can confidently say yes, not for all of the markers, but definitely for AMH and AFC. If we see here, the first two graphs here, we can see that both AMH and AFC follow the same, they have the same sensitivity and specificity, both for normal response, low response, and excessive response. So to the extent that now, for identifying any expected poor responders, it is they are utilized as the markers for identifying expected poor responders as per Poseidon criteria or even Bologna criteria. So whether we can say that yes, they are good for assessing, predicting ovarian response, yes, they are very good predictors of both low ovarian response or excessive response. Why it is necessary? If we know beforehand what the response is going to be, then obviously we can choose the protocol which we want to use, whether it is a long agonist or antagonist protocol, and then what should be the starting dose of the gonadotrophins, whether it should be standard 225 units or whether it should be lower dose than normal, because we don't want to have abnormally excessive response and end up having hyperstimulation, ovarian hyperstimulation in hyper responders, or we don't want to start with too lower dose in expected poor responders and then cancel the cycle, because they would need a higher than normal starting dose of gonadotrophins. So that is the advantage of using these markers to predict the ovarian response. And again, I have to stress that this is in the context of a conventional IVF program, and this cannot be extrapolated to any other scenario, including all other forms of stimulation used for IVF, be it natural or combination of oral and oral agents and gonadotrophins. So it cannot be they cannot be extrapolated to these scenarios. So I think the first question we wanted to answer is whether they are good predictors of ovarian response. Yes, in the context of AMH and AFC, they both are they both have very high sensitivity and specificity. Either one of them can be used to predict the ovarian response. We don't need to rely on both of them, but either one of them can be used equally. Now, coming to what about live birth following an IVF cycle. So if you see this table here, you can notice that if you look at the first column, they're all women below 37, below 40 years of age, actually, in this particular study. So if we use AMH in women between 25 and 40 years of age, we all, I think, know that AMH is not a very good predictor of predictor of ovarian reserve or ovarian response in women below 25 years, because it only peaks at the age of 25 years. So we should not rely on AMH values very rigidly in very young women. And above 40, I'll come to that a little later. So if we see in that most commonly encountered group of women, those who are in their mid-20s, late 20s, and in their 30s, we can see that compared to age, AMH is a better predictor of live birth, and then we can say that it is also a better predictor of oocyte quality. So there are some contentions about this statement I am making, and we will go through that in a little bit more detail in the next couple of slides. But we can see that somebody who has better AMH, but this is again restricted to women below 40 years of age. So those who are older, above 37, but have a better AMH, have a higher chance of achieving live birth compared to those who are much younger but have very low AMH levels, that is below 0.5 nanograms. So in a predefined or well-defined group of women with infertility who are going through IVF, we can use AMH also to predict the chances of live birth compared to age alone. So going a bit more into detail, one of the other things we would like to know is what about the oocyte quality? That is one of the issues we are addressing. So here is I'm just showing some of the latest studies. So this is about 4,000, nearly 4,500 oocytes were assessed among 400 plus women who are undergoing IVF. When we look at the AMH level and how it correlates to various parameters, so there is a significant correlation between AMH level and maternal age. I mean, obviously, it's an inverse relationship. As the age increases, AMH level decreases. But if you look at the ovarian response parameters, there is as the AMH levels increase, the number of oocytes retrieved, number of follicles developed increase, number of oocytes retrieved significantly increase, number of M2 oocytes increase. Fertilization rate also, there is a marginally significant. Number of embryos, number of high quality embryos, and number of transferred embryos are all directly correlated to the AMH value. So what about now going a bit more into details of AMH? These authors could not really identify a significant correlation between embryo quality and the AMH values, but there was a overall significant improvement in the occurrence of pregnancy. If we see the confidence interval, it could be anywhere from 3% to 53% increase in some, compared to somebody having low AMH. Somebody having normal range will have an increase anywhere between 3 to 53%. So similarly, oocyte abnormalities, were more common in those who had lower AMH compared to those who had normal AMH. What about, whether we can predict development of blastocyst compared to, in comparison to AMH levels? This was a retrospective study, but I've just, put this here because this just strengthens to some extent what we are trying to identify where all we can use AMH as a predictor of ovarian response or chances of pregnancy. So we know that it's a very good predictor of ovarian response. To some extent, it is also a good predictor in a well-selected group of women. It's also a good predictor of oocyte quality. And what about the blastulation? Yes, there is AMH and AFC are both very good predictors of pregnancy rate and live birth rate, but FSH should not be used for predicting either the ovarian response or the outcome of any IVF cycle. And I think that is something, a message that has to be taken home very clearly. Now, what about a selected group of women who are diagnosed to have low prognosis as per Poseidon criteria? What happens to using AMH in them as a predictor of cumulative pregnancy rate over 18 months? So these authors looked at women who were going through conventional IVF and ICSI, so multiple cycles of treatment. What they did show was cumulative pregnancy rate in low prognosis women over 18 months and multiple treatments was about 56%. So it is very important to know that AMH is a good predictor of cumulative pregnancy rate as well, because when we are talking about IVF, usually when we talk about cumulative pregnancy rate, we may refer to either live birth rate happening at the end of one cycle after completing all the embryos which have been used for fresh transfer or frozen transfer, or we may mean over multiple cycles. So this is where the issue arises, especially in countries where it is self-funded IVF, as to when we mean cumulative pregnancy rate over how many cycles. And on an average, we may take up to 3 to 4 cycles. But here, in these women, large majority of them required more than 3 cycles of treatment, but they do achieve a reasonably. Hello?
Sorry to interrupt, but your time is over. So
yeah,
you can
I'll finish in 2 minutes.
Yeah, sure. Yeah.
So AMH does predict a reasonable pregnancy rate over a longer period of time than what is expected in women with low AMH or AFC, or so-called low prognosis people. Now we come to the importance of using these ovarian reserve markers in relation to age. So this study, which looked at women below 38 years, and comparing those who had normal AMH, that is between 25th to 75th centile, and those who had less than 10th centile, there was a definite reduction in their ovarian response, but it did not correlate with the cumulative pregnancy rate. So maybe in younger women, low ovarian reserve doesn't necessarily mean poor oocyte quality. So that is why the ovarian, that is the advantage of doing ovarian reserve test in younger women, because if we identify those who have low prognosis or low ovarian reserve, then we can expedite the treatment in them, and try, because they tend to have a reduced reproductive lifespan, but not necessarily reduced quality. But what happens in older women above 40 years is a different scenario. Age-related reduction in the quality of oocytes dominates the ovarian reserve markers, even in those who have better ovarian reserve markers in women above 40 years. We cannot really say that the oocyte quality will be good. So it is the age which overtakes the importance of ovarian reserve markers in women above 40 years of age. But below 40 years, we can be cautiously optimistic. What about ovarian reserve markers? We have seen what happens in the IVF scenario, but what happens, whether we can extrapolate the information available to natural fecundability, because it is important for most of our women going through treatment. It's important as it can be a useful tool to assess fertility potential in general population, and also in women undergoing fertility treatment, but not necessarily IVF. Here we can see that there is, over a period of time, those who are trying to conceive naturally, there is no difference in the cumulative pregnancy rate over a period of time, whether they had normal AMH or low AMH. So we have to be very careful before using these markers to counsel somebody who just, like comes across, wants to find out what is her chance, her fertility potential. So we should be very cautious. And this has been in a large eager trial also has been shown that the cumulative pregnancy rate in those who have whatever may be the AMH level, the pregnancy rates are very similar. So we should not really be using it to predict natural fecundability in women. What we can probably say is that maybe the time span they have to achieve fertility is reduced, but we cannot say that they will not be able to conceive naturally at all. So I'll just skip that. This summarizes what I've said in the last two slides. So I would like to conclude that FSH, AMH, and AFC have been used to evaluate any association between abnormal ORT and oocyte quality. Both AMH and AFC are robust markers of ovarian response in conventional IVF and ICSI, but not otherwise. After initial promising evidence, currently age remains the most important factor determining the oocyte quality. So those who are young, we can with low ovarian reserve markers, we can say that they should not delay fertility. They should expedite their treatment. And if they have to undergo IVF, they may expect a lower response compared to those who have normal reserve, but it doesn't necessarily affect their pregnancy rate. Natural fecundability, now none of the ovarian reserve tests are considered robust enough to predict natural fecundability. Thank you.
So, thank you very much. You have elaborated so well on this subject, such a vast subject. I think you can go on this subject. Although 15 minutes, 15 to 20 minutes is very less for this, but very nicely you have concluded that FSH, AMH, and AFSC have been used to evaluate any associations between the abnormal ORT and oocyte quality. This is the fundamental what we could get through your talk, and the natural fecundability one. None of the ORTs are considered robust enough to predict natural. This is also very, very well explained, and throughout the graphs and the pictures, whatever your case is, very well explained, Dr. Madam. So, any questions? I think I'll have to see in the chat box.
But many compliments in the chat box.
Yes. Yes. So your talk was awesome, and it is very informative for the audience and for this certificate course. Very apt way of description. So thank you so much. And over to Dr. Minu Agarwal.
So
Do we need to?
Yeah, now we'll have our third speaker. So Dr. Pratibha Singh is here. Would you like to introduce our third speaker? The basis of this course, the main person for this course, Dr. Madhuri Patil, ma'am. So who's there? The chairperson, Dr. Supriya, madam. You will introduce Dr. Madhuri, madam?
Yes, I can. So thank you so much. So it was a real privilege to introduce Dr. Madhuri Patil, ma'am. She is an encyclopedia of these academics. I had heard her in the ISAR conference. She such wonderful talk she gives. Madam is the clinical director of Dr. Patil's Fertility and Endoscopy Clinic, Bangalore, associate editor of Fertility and Sterility and official publication of ASRM, and chairperson Aspire SIG Reproductive Endocrinology. She was in 21 till 25, president and founder member of Fertility Preservation Society of India, vice president and founder member of the PCO Society of India, vice president ISAR, board member of AE-PCO Society, governing council member ICOG 21 to 23. She'd been the member education and accreditation committee Aspire and Aspire SIG implantation, associate editor of the Oncofertility Journal, past editor-in-chief of Journal of Human Reproductive Sciences 2013 to 20, an official publication. Then she had been the winner of so many awards, Dr. Dudu Shah Lifetime Achievement Award from ISAR 2022, Vidya Bhushan Award from ICOG in 2021, and founder chairperson of Karnataka chapter of Indian Society of Assisted Reproduction, principal and course coordinator and examiner for fellowship and certificate course in reproductive that is Indira Gandhi University of Health Sciences, Karnataka, ICOG, and ISAR aspired, member of International, member of International Reproductive Medicine Research Network. She has got so many publications, and Madam has a huge CV, and Madam, all the viewers and the people who have logged in will benefit from your talk. So over to you, Madam, for your presentation.
Yeah,
And
thank
just
you
to
for that
add his
introduction.
talk behind this course, the entire scientific program, very, very nicely curated by Dr. Madhuri Patil. So thank you, madam, for this, and please go ahead for your talk. And you can give her a talk at just an hour before, and she says, okay, I will give this talk.
Thank you very much. And I would today talk on semen analysis. And we know that semen analysis is the first test what we need to do when an infertile couple walks into our clinic, even before we start investigating the female. And let us see what has changed over 10 years, because we had the 5th manual in 2010, and now we have the 6th manual, which has come in 2021. We know that sperm is a very sophisticated toolbox, which is optimally elected cell with high quality DNA, centrosome, RNA species, histone code, and yet so many other factors. And we also know that during its incredible journey, the selection of the best sperm at the site of fertilization is very important for conception. The sperm characteristic important for fertilization are a normal physiology and intact acrosome, a straight line velocity and linearity in its motility, its ability to bind to the zona pellucida, penetrate the zona pellucida and fuse with the oolemma and activate the oocyte, and also its ability to form a pronucleus. So as I said, it's a basic investigations, and we have to do it with 2 to 7 days of sexual abstinence according to the WHO manual. But I think best is to do it with 3 to 4 days of abstinence. If it is abnormal, then we have to repeat the semen analysis only after a month. Whenever a semen analysis is there, it's important that we have to enter the name and the personal code number of the patient, the period of abstinence, the date and time of collection, as well as the completeness of the sample. And the sample basically should be obtained by masturbation and ejaculation into a clean container made of glass or plastic, which is non-toxic. The container is then placed on the bench or in an incubator at 37 degrees centigrade while the semen liquefies. The sample is examined between 30 to 60 minutes after ejaculation. And for microbiological analysis, the specimen container and pipettes must be sterile. The analysis should be done as per the SOP. Collection of semen at home is a big no-no. Collection of the semen by using non-toxic condoms during sexual intercourse also should be avoided. But if the patient cannot ejaculate, then probably that could be one of the methods. Coitus interruptus again should not be practiced, and one has to look at the safe handling of the specimen in presence of infectious diseases. We also should remember that the results of the semen analysis will depend upon whether a complete sample is collected or not, whether the sperm-rich portion of the ejaculate has been collected, the activity of the accessory glands, the time since the last sexual activity, any difficulties in producing the sample, and also interval between the collection and the start of semen analysis, because if you have left the sample for quite some time, then surely your motility is going to reduce, and therefore you're not going to get a correct report. So what is different between the two manuals? So in the 2010, we had only people from Australia, Norway, USA, Denmark, Finland, France, United Kingdom, and Denmark, which were included when the manual was prepared. But now in the 2021, they also added men from China, Egypt, Greece, Iran, as well as Italy. So what do we look for when a semen analysis, when we perform a semen analysis? So first thing is we have to look at the liquefaction, and we know that the normal sample liquefaction occurs within 15 to 20 minutes. If liquefaction is delayed more than 30 minutes or does not occur at all, it should be reported in the final report. And this may be due to abnormal prostate function due to an infection in the genital tract, prostate or seminal vesicle, artifact as a result of the use of unsuitable type of plastic containers, or even in those men who have frequent ejaculation. The normal volume is anywhere between 1.5 to 4 ml. Low volume may be seen in the presence of obstruction of the ejaculatory duct due to previous infection of the genital tract, congenital absence of the seminal vesicle and vas deferens, which is associated with absence of fructose. There could be retrograde ejaculation, especially in those men who have history of previous surgery of prostate or the bladder neck, loss of fraction of the ejaculate during collection, as well as when there is androgen deficiency. Normally, the pH is about 7.2 or slightly more. It is more or bilateral epididymitis. It's less than 7.2 in the presence of chronic infection and less than 7 in the presence of obstruction of the ejaculatory duct, the congenital bilateral absence of vas deferens in the presence of azoospermia, and cases where only prostatic fluids have been secreted. So how do we do the semen analysis? Basically, we have to allow it to liquefy for 30 minutes at 37 degrees centigrade. There are two methods. One is you could use the hemocytometer, but this is too complicated, and I personally don't like to use it, wherein you need to do the counting in the C part of the central chamber of the hemocytometer, which has 25 large squares, and then out of that you need to measure one square, which has 16 squares. And if the sample has less, then you have to probably count the entire grid of the C, that is all the 25 large squares. If you have between 10 to 40 spermatozoa in this, then you have to count 10 of these. And if you have more than 40, you have to count more than 5. And the most important is the sample needs to be diluted 20 times when you're going to do a semen analysis in a hemocytometer. So I preferably would like to calculate in a Maker's chamber. Though it is expensive, you need not dilute the sample, and the amount what is required is 1 microliter, which fits below the cover slip. And when you count, if the count is normal in 10 squares, you get the entire count, and from that you can count the motility as well as the, you can also look at the morphology. So in the 2021, the total number of sperm should be more than 16 million as against more than 15 million in the 2010. But the total number of ejaculate sperm, the number of sperms in the ejaculate remains the same at 39 million. When there is low or absent sperms, examination of the sediment of the centrifuge sample is essential. If we find sperms in them, then we know that it's a case of cryptozoospermia. And if they are absent, then we have to suspect azoospermia and go on with further investigations for azoospermia. Coming to sperm motility, we have 4 different types of motility. One is rapid progressive, slow progressive, non-progressive, and immotile. So according to the 2021, A plus B plus C should be more than 42, as against 40 in the last edition. And A plus B is supposed to be more than 30%, as against 32% in the last edition. And the motility is calculated in a Maker's chamber by multiplying 100 into the total number of sperms with particular type of motility, that is rapid linear, slow linear, non-progressive, and immotile, and that should be divided by the total number of sperms in those 10 squares, which would give you the percentage of motility. Vitality is again very, very important, where we have to evaluate at least more than 200 sperms. We have to stain the semen sample on a slide with eosin and nigrosin stain. And those with red basically those are dead, and those which are white are live sperms. And the 2021 desires more than 54% live, as against 58% in the previous edition. The sperm morphology is basically calculated by Shaw's stain or the Papanicolaou stain. And basically you need to prepare the slide, and then you need to stain it. What we use in an ART lab is basically the Kruger's criteria, that is at least more than 14% need to be normal. But according to the WHO criteria, it's just 4% that need to be normal. So each spermatozoa then is evaluated as normal and abnormal, and the percentage of normal sperm cells in the ejaculate is evaluated and related to fertility according to the threshold. So you can have head defects in the form of the head could be tapered, pyriform, round, amorphous, vacuolated, or small acrosomal. There could be neck piece or mid piece defects where you can have a bent neck. It could be asymmetrical. There could be a thick insertion as you see over here, or a thin insertion. There could be tail defects where you could have a short tail, a bent tail, or a coil tail, and there could be excessive residual cytoplasm as seen over here. So these are the different anomalies as we have already seen, which can be seen in the head, midpiece, as well as the tail. Then we also need to go for counting of cells other than the spermatozoa, wherein we have to look at the presence of white cells, which could be either polymorphs, epithelial cells, histocytes, or ghost cells. And they have to be less than 0.5 to 1 million per ml. The round cells or the premature germ cells should be less than 5 million per ml. And what we use is to differentiate the red cell, the WBCs from the premature or the round cells is the peroxidase activity or the leukocyte marker. And this is done using the orthotolidine test, which is immunocytochemical staining. Presence of large number of peroxidase stained cells indicates the presence of accessory gland infection. And if they are more than 1 million, then probably a semen culture should be advised. Many a times people just look, and even if they see the round cells, they find their WBCs, and unnecessary semen culture is advised. So it's very important at this point to differentiate between immature germ cells as well as the WBCs. And in the immature germ cells, you can have spermatogonia, spermatocyte 1 and 2, round spermatids, as well as elongated spermatids. And all these could be mistaken as WBCs. Then we need to look for agglutination, and we know that we have two types of agglutination. One is a non-specific agglutination, as you see over here, where the sperm just stick to the cells or the debris, whereas you have specific agglutination where the sperms stick to each other. And this is basically related to the presence of anti-sperm antibodies and is tested by different tests like immunobate test and the mixed antiglobulin test, which has to be less than 50%. So the incidence of having sperm agglutination is significantly higher in the infertile population as compared to the fertile population. And basically, it is seen in those patients who have infection, who have undergone vasectomy, and who have presence of anti-sperm antibodies. The sperm biochemistry is also very, very important, the semen biochemistry, and this tells us about the function of the accessory sex glands. We have to evaluate fructose for seminal vesicles, zinc and acid phosphatase for prostate gland, alpha glucosidase, GPC, and L-carnitine for epididymal function. Then there are certain sperm function tests which we could do. One is the hyposmotic sperm test, a detailed sperm morphology called as the TZI or the teratozospermic index, a trial wash with sperm survival, anti-sperm antibodies, CASA or computer-assisted sperm test, and a mucus penetration, which we rarely do nowadays, a sperm DNA fragmentation, and assessment of reactive oxygen species, because it can affect fertility. And when it affects the mid-piece, it can affect the motility. If it affects the acrosome, the gamete binding, and if it affects the sperm head, it can result in DNA damage. HOS basically gives us information about the vitality as well as membrane integrity, and it has a good correlation between the spermatozoa showing positive HOS and fertilization rate at IVF. And today, in this edition, they have not changed much about the HOS, and it has to be more than 50%. And basically, you can divide it. Normal is more than 60, borderline is between 50 to 60, and abnormal is less than 50. And though if it is less than 50, basically these patients would benefit with ICSI. Now, in the 2021 manual, apart from the TZI index, basically, they have also looked at the multiple anomalous index and the sperm deformity index. So in the TZI, it's we know that we do it routinely, and it's a good predictor of the fertility for fertilization rate as well as the pregnancy rate. And it is basically a multiple anomalous index where the total number of sperms counted 100. We record the normal and abnormal sperms. Then the abnormal sperms can have 4 abnormalities. So the total number of all separate abnormalities is then divided by the number of abnormal sperms counted, and this gives us the gives us the TZI index. And normally it has to be basically less than 1.6, and if it is more than 1.8, ICSI is done irrespective of the count and motility. So they have, these are the various indices, and then the other denominator is always the abnormal sperms, whereas in the SDI, it is all sperms. And this is how we calculate the abnormal index. And if you see the fertile and infertile population, the TZI, as I said, the mean is 1.81 as compared to 1.51 in a fertile couple. DNA damage can be assessed by either comet assay, tunnel sperm chromatin, or halo assay. Normal is less than 15. If it is between 15 to 30, I mean, the fertility is still good and fair. But if it is more than 30, it has low to poor fertility. And it has been seen that 8% of infertile men have abnormal DNA integrity despite normal semen parameters. And it's basically should be done in those patients who have unexplained or persistent infertility, who fail to conceive after 5 to 6 IUI cycles, who have a low fertilization rate or poor embryo quality at IVF cycles, have repeated implantation failures after IVF, recurrent miscarriage, prolonged stay in an environment that exposes to reproductive toxins, abnormal semen analysis, and if the age of the male partner is more than 45 years. So when we look at the reference values for many parameters have changed in the 2021 manual, and this would tell you that the semen volume has been reduced from 1.5 to 1.4. The total sperm count per ml from 15 to 16, total motility from 40 to 42, progressive motility from 32 to 30, vitality from 58 to 54, whereas all the other parameters have remained same. And what therefore it was said earlier that the total motile count is a better indicator of severe male factor as compared to the WHO manual. Yes, I'm just finishing.
Yeah.
So the couples who have a total motile count of less than 5 million have significantly lower chances of spontaneous pregnancy, as you can see over here. And those with more than 10 million have the same, less than 1 million have the same spontaneous as couples with between 1 and 5. So there's no difference between that. And the couples with normal would have the normal pregnancy rates, whereas with unexplained, they have a higher chance of spontaneous as compared to those with other factors. So the predictive value is very poor of the semen analysis, and about 40% of infertile men have semen parameters that overlap with the fertile men, and extremely poor or just below the cutoff results are pooled into one group. And therefore, impaired semen parameters alone cannot be used to predict the fertility, as these men still have a chance of being fertile, except when a man has azoospermia, necrozoospermia, and globozoospermia. And therefore, basically, semen analysis only provides a direction for further evaluation and treatment. If it is normal, there's no therapy needed. If it is abnormal, if it's non-treatable, then one needs to go for adoption or donor insemination. If it is treatable, we need to offer rational therapy, optimize the female reproductive function, and then go for assisted reproduction. So I would like to conclude by saying that standardization of andrology laboratories is essential. Semen analysis results cannot be used as a sole criteria for decision making. Multiple parameters may give better predictive value. Use of a predefined treatment algorithm and data collection will be critical for improving our understanding of fertility potential of our patients. Semen analysis is only a gross estimation of fertility, but it is unfortunately the best test we have, and it can predict fertility in men with azoospermia, severe astenospermia, and globozoospermia. And in other cases, the semen analysis have a limited role in the evaluation of infertility because female factors can influence fecundity in most couples. Thus, semen analysis alone is usually insufficient for diagnosis because it does not account for sperm dysfunction such as immature chromatin, oxidative stress, and DNA damage. I thank you all for a patient hearing.
There is one question we can just take. If agglutination test is positive, then what should we do next?
Yeah, so if it is positive, one is we have to rule out infection, and second is we need to rule out the presence of anti-sperm antibodies. These are the two things what we need to rule out. So if we have not done the culture, we need to do culture, and then we need to give antibiotics for 15 days. Doxycycline is the best form of best antibiotic that can be given. And after a month, probably we should repeat it. But these many a times, if they have presence of anti-sperm antibodies, then probably one could try 2 to 3 cycles of IUI. And if that is not working, then it's best to go for ICSI, because we really cannot reduce the anti-sperm antibodies which are there.
That was an awesome lecture on semen. I think one of the best lectures that I've heard on a semen analysis. You have covered everything right from the counts, the motility, and the morphology of the semen sample. And I lot of good reviews by the doctor, by the delegates. Excellent talk, very nice. So many positive reviews. And shall we go for the next session now? Srishti, would you like to introduce our next chairperson for the second?
Yes, ma'am.
Thank you, Madhuri ma'am. Thank you, Madhuri ma'am. And this lecture was prepared in 1 day's very short notice also, I should say that. Thank you.
Thank you, everybody, the chairpersons and the speakers for session 1. It was a very informative and a great session. Moving on to our next academic session on the basics of IUI, I would like to introduce our chairpersons. Our first chairperson is Dr. Ashish Kale, sir. He's the director of Asha Kiran Hospitals in Baner, Pune, Asha IVF Center, Pune, and sir is the director of Arunachal IVF Center, Pune. Sir has been the vice president of Pune OBGYN Society from 2018 to 19. He's a librarian at the Maharashtra chapter IAGE, the executive member of National ISAR, the chairman of EMOG's Infertility Committee, and the executive member of Maharashtra ISAR. Sir has had many awards to his name, like the Champion of ISAR Award 2020. Sir is also the recipient of Kamini Rao Oration Award of 2017, the FOGSI Future Award, and so on and so forth. It is a privilege to have you here, sir. Welcome.
And very pleasant and very helpful, I would like to add for Ashish.
Our next chairperson is Dr. Girija Wagh, ma'am. Ma'am is the professor and head of Department of Obs and Gynae at Bharatiya Vidyapeeth Medical College and Hospital in Pune. Madam is also the senior consultant Cloud9 and Apollo Hospital, Pune. Ma'am has been the faculty professor at the OJASH International Experts General Coordinator in 2016. Ma'am has been the chairman of the Medical Disorders in Pregnancy Committee of FOGSI 2012 to 2016. The Vice President of India Chapter of Gestosis, the Member Governing Council of ICOG, the Joint National Secretary of FOGSI in 2010, the Assistant Coordinator for National Eclampsia Registry since 2008. Ma'am has been the member of Central Supervisory Board of the PCPNDT Act from 2010 to 2014. She's the national mentor for the Lakshay NPOQCN for the Government of India program. And ma'am has received the Anandi Bai Joshi Award for Excellence in Medical Services. We welcome you, ma'am.
Hey, Girija, can we see? Are you there?
Ma'am, ma'am is traveling. I called her. I think she's traveling, so she's having connectivity issues.
No problem. No problem.
Our next chairperson is Dr. Manish Pandya, sir. Sir is the professor and HOD at the Mahavir Hospital and Manish IVF Center. Sir is a dynamic Indian of the Millennial by the KG Foundation and the Gynac Excellence Award by FOGSI in 2020. He's the commendable editor-in-chief by ESRF in 2021. Sir has written 8 books by JP Publication, has published many papers in multiple journals and has received multiple awards for the same. We welcome you, sir. It is our honor to have you here.
Thank you.
Without further ado, we move on to our second session. And I would like to call upon Dr. Manish, sir, to please introduce our speaker for the next session.
Thank you. At the outset, I would like to thank Professor Meenu and my teacher Parul Kotlawala sir for giving me opportunity to be a part of ICOG 3 days certificate course. And first speaker is Dr. Charmila. She's very good academician. Was Vice President FOGSI, 2024 Vice President Trichy Society, ICOG Governing Council member, National Coordinator, Senior Convener of ICOG, WHO Southeast Asia Region, MDSR, India member, President of Menstrual Hygiene Management and Consortium 2018 to 2020. She served as a Secretary of Gestosis India Association, Academic Wing of Assisted Reproduction Trichy, MC member and PCOS Society of India. So welcome, Charmila madam. Stage is yours. And as always, you are rocking. Just rock the show, madam.
Thank you, sir. Thank you. Not very clever, very sharp, and very intelligent, Charmila. Thank you, Meenu. Thank you,
Name
Pandya
itself
sir.
suggests, madam. She is always charming. Aaj mila, tu mila, kal mila, she Charmila.
Thank you so much. So, Meenu has given me a topic where I need to talk on the current status of IUI and particularly the patient selection and whom and how many we need to do. We need to know that IUI is a technique where the natural process has failed in some patients because many studies have shown very disappointing results regarding the capacity of the motile sperm to reach a fallopian tube after intercourse. And there's a very important reduction in sperm number along the length of the female reproductive tract, and that has been proved in so many studies. And the very striking is a finding that only 1 in every 14 million motile sperm deposit in the vagina will reach the site of fertilization, the fallopian tube. So nature is not so good as far as conception is concerned. And when you want to know the results of IUI, it's the first line of assisted conception technique, which is the least invasive compared to IVF and ICSI, and it's most cost effective. The success rate works out to per cycle pregnancy rate of 10 to 20%, and the cumulative pregnancy rate is around 30 to 45%. And it can vary individually from 5 to 70%, quite a varied result that IUI gives. The clinical use of this technique is based on the hypothesis that placing a large number of sperm high in the reproductive tract will enhance the likelihood of conception. IUI with or without ovarian stimulation has become the first-line treatment option for many infertile couples worldwide. So it's still an acceptable technique. And the requirements for IUI is the minimal requirement will be ovulation in the IUI cycle, which is being tried for the patient. There should be 1 fallopian tube, which is a patent. You need to inseminate with an adequate number of motile sperm. And you need to document that there's no active cervical, intrauterine, or pelvic infection before you do an IUI. There are certain questions in IUI which needs to be answered. The indications for IUI. When will you do IUI versus expectant management? What are the sperm parameters required to get a good result? The best and optimal method of timing and the number of inseminations per cycle. What are the preventive strategies to decrease multiple pregnancies and the cost effectiveness of IUI versus IVF? These are all questions asked in ESHRE 2018. It was answered by the special group for IUI. And according to them, the main indications for intrauterine insemination is unexplained infertility, which includes a mild endometriosis, male factor infertility, and female cervical factor. There are some minor indications for IUI where the first is anovulatory infertility of PCOS patients and not conceiving by the conventional timed intercourse can be offered IUI. Minimal to mild endometriosis comes here also. Sexual dysfunction,
immunological abnormalities, azoospermia for IUI with donor sperm. The contraindications of IUI is cervical atresia, cervicitis, endometritis. Suppose both the tubes are blocked, or it's a case of amenorrhea or severe oligospermia, IUI is contraindicated. The rationale behind IUI is to increase the gamete density at the site of fertilization, even when sperm or cervical mucus abnormalities are present. And the increasing use of this technique in idiopathic, that is unexplained infertility and male infertility, is mainly because of the result of the refinement of techniques for the preparation of washed motile sperms as used in IVF. So the technique for preparation of sperms is evolved, and that has contributed to a little higher success rate with IUI compared to earlier days. And you have to put the maximum number of gamete at the site of fertilization in the fallopian tube when there are abnormalities in sperm or cervical mucus of the female. In unexplained infertility, it has got a good role to play. But if there's a good prognosis for the patient to become pregnant, even without any assistance like IUI, the next 12 months, that is, it works around 30%. That is, a couple with unexplained infertility, have evaluated her and all her parameters are normal, and she's been married only for 1 year, you can actually wait for the next 12 months expecting her to become pregnant. So 2 years of unprotected intercourse may work out in case of unexplained infertility, and the pregnancy rate estimate is almost 30%. And there you can actually postpone IUI for the next 6 months because they've got a higher chance of becoming pregnant by themselves. And do not offer IUI in natural cycles to patients with unexplained infertility because the success rate is quite low. And so when a couple has got unexplained infertility and the total motile sperm count is more than 10 million in a prepared sperm sample, it is recommended that you offer her intrauterine insemination with ovarian stimulation. You should not offer her IUI in a natural cycle. Regarding male factor infertility, IUI can be tried when there's only poor sperm quality. For very less numbers, IUI may not work. So the quality of the sperm in the form of teratozoospermia or any other form of problem with the quality of the sperm, you can try IUI. And when is ovarian stimulation required in an IUI cycle? And as I explained, it's when there is unexplained infertility and the male partner's got a good count, which is a total motile sperm count of about 10 million. Then you can offer the couple IUI, but it should be always combined with ovarian stimulation. Do not offer her in a natural cycle. And what about the sperm quality and thresholds, which will give you a good result with IUI? The SRA has clearly said sperm quality and sperm count cannot define IUI results. And it's not possible to define any clear low cutoff value to say that this amount of pre or post-wash sperm parameter below which you need not give IUI. There is nothing like a lower cutoff value to say that this sperm parameters will not be applicable for offering IUI to the patient. So it is all left to the discretion of the clinician. And how do you time insemination in IUI cycle? Suppose you have stimulated her, you need to give her, you've given her a HCG injection for a trigger, you will do a single IUI anytime between 24 hours to 48 hours after the HCG injection. And they say to not compromise the pregnancy rates. But in a natural cycle, we have not done an ovarian stimulation. You need to do the IUI 1 day after the LH started rising. And when compared to IUI, fallopian sperm perfusion is not the treatment of choice. The results do not improve just because you inject 4 ml of semen volume into the seminal plasma, into the seminal fluid into the fallopian tube. The results are not so great. And what are the optimal number of inseminations per cycle? In both unexplained and male infertility, there is insufficient evidence to do a double IUI within the same cycle. It is equal to giving a good pregnancy rate as in a single IUI. So women who are undergoing IUI for an indication which you feel can help her should be offered only a single insemination per cycle. The double inseminations do not work. And what about bed rest after IUI? When a lady undergoes IUI, she should be offered 10 to 15 minutes of bed rest after an insemination. And the number of IUI cycles which will give a good result is in a couple with an indication for IUI, that is, it can be unexplained or male factor infertility, please offer her 3 consecutive IUI cycles. There is insufficient evidence to actually give a cutoff of the maximum number of IUI treatment cycles. So minimum is at least 3 consecutive IUI cycles, but the maximum number of cycles have not been defined. And what is the best semen preparation technique for IUI? At this point of time, every technique seems to be, there seems to give the same result. It can be a swim up technique, can be a gradient technique, single gradient or double gradient, it can be a wash and centrifugation, all seem to give equal results. Cost effectiveness, when you compare with IVF in conditions where IUI indicated, that is particularly unexplained infertility and male factor infertility, at least 3 cycles of IUI with ovarian stimulation is still a very effective option when compared to IVF, because the cost effectiveness is there when you do an IUI compared to an IVF. And how do you prevent infections in an IUI lab? All the couples and the individuals undergoing IUI and the males who are providing the semen samples for IUI should be screened for infectious agents, and that will be based on local, regional, and national standards and regulations. And how do you prevent a multiple pregnancy and ovarian hyperstimulation syndrome in an IUI cycle? Suppose you have stimulated her and there are more than 2 dominant follicles which are more than 15 mm, or there are more than 5 follicles with size more than 10 mm at the time of HCG injection, or there's an LH surge, please avoid giving the HCG injection because that will cause her to go for OHSS or multiple pregnancy. And when you're using gonadotropins for ovarian stimulation for IUI, please use regimes with 75 units or lower. And because higher doses will have similar pregnancy rates as with the lower dose, but the chance of pregnancy rate, multiple pregnancy becomes much higher when you're using higher doses of gonadotropins in IUI cycles. And what are the drugs which are used for ovarian stimulation? Clomiphene citrate, tamoxifen, letrozole are all acceptable alternatives to low-dose gonadotropins because they will lower the chance of multiple pregnancy. And the birth rates actually equal when you use gonadotropins as in oral ovulogins with lesser cost. But there may be a slightly lower live birth rate with oral ovulogins compared with gonadotropins. And adding GnRH agonist to gonadotropins to prevent a premature surge is not recommended because there's no increase in pregnancy rate, but there will be an increased multiple pregnancy cost, and it's going to increase the cost of therapy. And to avoid cancellation of IUI cycles when you're seeing multiple follicles, instead of cancelling the cycle, you can aspirate the excess follicles at the time of HCG injection or the LH surge, and those will be additional options for reducing the risk of multiple pregnancy or OHSS. And this is the reference for all those recommendations. And what about PCOS and IUI? Currently, the mainstay of treatment for PCOS patients is ovulation induction with timed intercourse. But this is not effective. Many patients are being offered empirical IUI or IVF as secondary modalities of treatment. The benefit of IVF in patients who are not conceiving in PCOS is established, but the benefit of IUI is still not proved. And it's unknown if IUI will add any clinical benefit in this population. And the IUI will not improve pregnancy outcomes, rather it will become more expensive and invasive for the patient who's on polycystic ovarian syndrome. And what about the endometrial thickness and the pregnancy rate with IUI? There's no correlation between endometrial thickness and pregnancy rate, but an endometrial thickness which is less than 6 millimeter may indicate a lower chance of implantation. And luteal phase has to be given with vaginal progesterone. It will significantly increase the live birth rate in IUI patients who are using gonadotropins for ovulation induction and rather than oral ovulogins. And this is what William Omblet said, what will be the bad prognosis for a patient who's attempting IUI and compared to a good one. A bad outcome in IUI can be expected if the duration of infertility is more than 4 years in the couple. Suppose the sperm is of very poor quality, that is, there's a total motile sperm count of 3 million or less than that. If the female partner is more than the age 40, suppose there's an untreated severe endometriosis, or there's a distal unilateral tubal factor, all this can contribute to a poor outcome with IUI. And there'll be a good outcome when there's ovarian stimulation along with IUI in case of unexplained infertility with endometriosis or in mild male factor where the total motile sperm count works out to be at least 10 million. And William Omblet said, if the tubes are open, there's no reason not to do an IUI. So IUI should be the first option in many of our patients who are not responding to the conventional therapy before you go on to the expensive IVF. Thank you so much. I see with you as well as Dr. Meenu for the opportunity.
Thank you very much, Charmila madam. IUI make patient happy. That is IUI. Okay. And William Oblet's last was very good, that the tubes are open. You have to give fair chance to all the patients to become pregnant when there is a male factor infertility. So very good, madam. Congratulations. And congratulations, Meenu madam, again for giving us opportunity.
Thank you. Thank you. There are some questions in the chat box. So, Dr. Charmila, can you just answer the questions in the chat box itself?
Yeah, I will answer that. I'll answer that. Yeah, thank you.
And all the faculty, and please answer the questions in the chat box. Thank you. Dr. Supriya, आप muted हो. सुप्रिया आप म्यूटेड हो. अच्छा, ओके. यस, सृष्टि आप म्यूटेड हो बेटा.
हाँ जी मैम. Ma'am, I would now request Manish sir to please invite the next speaker.
So I am the only chairperson present. At present, I am only present.
I just wanted to say one thing, Dr. Charmila, extremely good presentation. Always I like to hear you, Dr. Charmila madam. So
Yes,
that
ma'am.
just I wanted to give my appreciation to you. Wonderful talk. And
Thank
very
you.
crystal clear. That's it. Thank you.
Thank you.
So we have
Because
got-
Meenu wanted me to be very clear. She gave me that topic, whom to do, how, not how to do and all. Can you give or can you not do?
You are always on a streamline because I am listening you since long. You are always on a streamline, no left, no right. Go on the straight. Whatever topic given to you, you are giving full justice to it.
Thank you so much, sir. Thank you. Sir.
Positive comments in the chat box as well for you, Charmila.
Thank you.
So with permission of Meenu Madam, I would like to request Dr. Rakhi Dhawan Singh. She is president of NOGS, vice chairperson UP State ISAR, peer reviewer of our Jogi, chairperson endocrinological committee from 2020 to 23. She got lots of awards. She was invited faculty for 350 national and international conferences, FOGSI DC Datta Award, FOGSI CS Don Award Prize, written chapters in FOGSI books, and looking, madam, you are looking wonder. So you had got the Wonder FOGSIan Award, Dhira Award, and ICOG Appreciation Award. So dice is yours, or webinar is yours, or camera is yours. Do the justice to the topic, madam.
Thank you, sir. At the outset, I would like to thank the chairpersons for introducing well for me, and respect to Dr. Parul sir, who's the chair of ICOG, Sarita Bhalerao ma'am, the secretary of ICOG, Dr. Meenu Agarwal, and all the present esteemed faculty at this webinar, and all the delegates who are there, who are listening to us. Since we're going to talk on ovulation induction and IUI, most of the things which have been covered of ovulation induction and where the IUI has to be done, how it has to be done, how the semen has to be prepared, what is the quality of the semen. Let's understand a little bit about the induction. The basic aim of our ovulation induction would be to have a monofollicular growth and carry out the procedure that is timed intercourse or the IUI which has to be done. In the other AIT cycles, multifollicular genesis can be there with a controlled hyperstimulation, but our goal is to have a healthy pregnancy outcome ultimately. Failure to achieve a clinical pregnancy even after 12 months of regular unprotected intercourse is all what we understand. And here in India, around 3.9 to 16.8 is the percentage of infertility, and there are various causes for the infertility, but the disordered anovulation accounts to about 30% of the infertile couples and the cycles. Does it really makes a difference that the appearance of the patient, the age of the patient, and from where which background one comes for the ovarian stimulation protocols, for the decision making of the type of ovulation induction, what we are going to give, what we are going to offer, and what are the challenges which we are going to face while deciding a stimulation protocol for the developing world or our patients. And individualization of the ovarian stimulation protocols is the answer for it. And one key template doesn't fit for all, which we understand. And accordingly, we need to tailor-make the protocols, the drugs for our patients according to their needs and according to their response to what we give. And it also depends upon the ovarian reserve, what the patient has. Depending upon that, also the stimulation protocol depends upon it. Another part which we rely upon the stimulation is the body mass index, which predicts the infertility outcome, whether the patient is with PCOS or without PCOS, and extreme body mass, where the patient is standing. As obesity was associated with fewer normal fertilized oocytes, with a lower estradiol rate levels and lower pregnancy and the live birth rate, infertile women requiring treatment should be encouraged to maintain a normal weight during pregnancies and reduce if they are obese. Ask them to reduce at least little bit. That would help them out for having a better outcome. There are various stimulation protocols what we can use, but we are going to, as I'm emphasizing, monofollicular or 2 to 3 follicles, not more than that is our aim. And there are various prerequisites before the ovulation induction. What we're going to do, most of them, these prerequisites are the same as which goes for the IUI, which Dr. Chamila has explained. And basic hormonal evaluation at times needs to be done. And the viral markers, because we are planning for IUI, viral markers are important for these patients of ours to do it. And polycystic ovarian syndrome is little different. PCOS is little different for these patients of ours. For the stimulation, sometimes these PCO patients don't stimulate easily, or they may stimulate excessively with the hyperstimulation can be seen because they are having hyperandrogenism, and they have to be taken with care. Anovulation in these PCOS is because of the supraphysiological synthesis of estrogen, strong negative feedback signals or to hypothalamus and the pituitary, low GnRH production with positive feedback on LH, low FSH and LH, and no ovulation is seen in these patients. What are the objectives for ovulation induction? Clomiphene has been used for more than 55 years for the ovulation induction, but it has its own problems. Do we have any alternative in place for these clomiphene selected cycles or cases? Basically, what we have to understand what we want is induce monofollicular development of the ovulation. PCOS with anovulation constitutes to around 60 to 85% of WHO2 women who would benefit for ovulation induction therapy. And there are various drugs, as we had told, clomiphene citrate or the letrozole. Tamoxifen is also there, as Charmila has pointed out, but we don't use that widely. Or gonadotropins, which can be used for the ovulation stimulation for IUI. Remember, gonadotropins, what we're going to use is little less when compared to the IV of what we're going to use. When we talk about clomiphene citrate, which was the first line of management, and ovulation occurs in around 60 to 80% of the cases, and pregnancy rate is 10 to 20% per cycle. And failure to these 6 cycles, if the patient doesn't respond in this first 6 cycles with clomiphene citrate, that should be the end point. We are not supposed to give more than 6 cycles of clomiphene to our patients. And what happens when we are giving clomiphene citrate? It depletes the estrogen receptors in the pituitary and hypothalamus due to prolonged stimulation. Estrogen feedback loop gets interrupted. Thus, FSH secretion increases, leading to multiple follicles in the growth. And that is why in these patients with COCs, we find multiple follicles which are there, which are smaller in size, whereas the larger follicles are also there. And because of this anti-estrogenic effect, it contributes to the reduced pregnancy rate, and the miscarriage rate with clomiphene citrate is seen to about 26%. And there is also an entity called as clomiphene resistance or clomiphene failure, which we encounter in these patients. And if these patients who are not responding to CCs, they could be either because of the obesity with high BMI, or the insulin resistant patient, or hyperandrogenic state, or LH, which can be high in as seen in PCOS, or the resistant luteal cyst, which are mostly seen in CC cases. And a word about letrozole, which is another wonder drug which is there, and it is a 3rd generation aromatase inhibitors. And this letrozole has a good absorption capacity, which absorbs within 1 hour and a bioavailability of 99%. And metabolism, it is inactively metabolite, and excretion is 90% by the renal, and it is well tolerated. And no accumulation effect occurs in letrozole, whereas the accumulation effect of the drug with clomiphene citrate is seen in CC patients, which is taken forward for the next 2 or 3 cycles. And as we all know that it is not anti-estrogenic, and thus we have a good endometrium which is going up with these letrozole stimulated cycles. For induction of ovulation in women with anovulatory infertility, normally what we give is 2.5 milligram once daily, or 2.5 milligram in 2 divided doses twice daily. That is 5 milligram per day also can be given for 3 to 7 days for 3 consecutive cycles. And mostly the pregnancy occurs if everything goes all right. When we compare about the advantages of letrozole over CC, CC is basically a SERM, whereas letrozole is aromatase inhibitors. The half-life of clomiphene citrate is very long, that is 5 to 7 days, whereas the letrozole has a short half-life of 45 hours. And uterine blood flow is decreased because of the clomiphene citrate, and it increases in letrose. And miscarriage rates are quite high with clomiphene when compared to the letrozole. Multiple pregnancies thus is little on a higher end with clomiphene because of the multiple small follicles, which also are developing less than 10 millimeter size, which would be seen apart from the bigger follicle, which is ready for rupture. And letrozole was superior to clomiphene citrate as a treatment for anovulatory infertility in women with PCOS, but not so in obese patients. Letrozole was associated with higher live birth rate and ovulation cycles. There are various research councils and the guidelines which are also in favor of letrozole when compared to clomiphene, which gives a more of a morofollicular growth when compared to the others. If the patient is still not responding with oral ovulagens, we move a little higher up. We add upon gonadotrophins for these patients, either CC with gonadotrophins or letrozole with gonadotrophins would give a better outcome for us. And gonadotrophins, normally what we give it either in the resistant patients or with the failure patients of CC and failure to respond to letrozole, add little amount of gonadotrophins. That would be very good. Now the question arises, which type of gonadotrophin? Either the urinary, highly purified, or the recombinant. Ideally, what is given is urinary or highly purified, because we are thinking about the cost factor also. Recombinant is little costlier, as it is we are going to save them for the next cycle. Otherwise, if the patient wants, we can give a recombinant also. If it is a very thin, lean patient, and since this urinary or highly purified come in 75 and 150, if you want to give very less amount of dose, then we can manipulate and give it according to it in the recombinant forms, where you can decrease the dosage. And which day to start the gonadotrophins? If the patient is, if you want multiple follicles, then start on day 2, which we don't want in IUI cycles. And basically what we want is monofollicular or 2 or 3 follicles in IUI cycles. So give little amount of gonadotrophins on 5, 6, 7, or depending on it. Now the regime or the protocol which can be given is either we go step up protocol or step down protocol. Ideally, it is best to go for the step up protocol rather than to go with the step down protocol by giving a higher dosage first and decreasing the dosage. Little amount of gonadotrophins means it gives work. It works for 1 or 2 follicles. Now, when the follicles are ready, to have a 2 to 3 follicle of around 18 to 20 mm is the ideal what we are looking at. Endometrium, what we are looking at is more than or equal to 8 mm with a trilaminar endometrial thickness and a good vascularity which has to be seen. But anything above 6 mm is good enough if the vascularity is good. IUI, as Charmila has explained, anything from 36 to 40 hours post HCG trigger, or the IUI can be done earlier to 36 hours, that is up to 24 hours also, if the patient is having LH surge, which is coming up early, which can be made by a good ultrasound and which has been very well explained by the sonologist in the previous lectures. The question arises of the trigger, ovulation trigger, the end point for any ovulation induction protocol. The best trigger, what has to be given. If we are going to go in for IUI, then definitely HCG is the one. We are not planning to give any GnRH analogs. And given evidence suggests that we need to prevent OHSS. If you are having multiple follicles, then either, as Charmila told, aspirate the other follicles and do an IUI, or just defer with the IUI and ask the patient to abstain from that cycle to prevent multiple pregnancy and OHSS. And remember, our aim, I'm repeatedly telling, for an IUI cycle is maximum 2 or 3 follicles. And we've already understood that ovarian reserve is important for any patient to be stimulated. Down regulation is not required. And if it is required, only if there are visible cysts, and differ with that cycle of stimulation if there are visible cysts, that is luteal cysts, which are present from the previous cycles, and controlled ovarian hyperstimulation has to be given. And little amount of gonadotrophins definitely improve the success rate. And HCG trigger is the best, and maximum dosage of HCG which can be given is around 5,000 units, not 10,000, which is not required for any of the IUI cycles. Thank you.
Thank you very much, Madam Rakesh Singh. You had pointed out very nicely, and we had done comparative study of CC with letrozole, published paper also, and as a poster in Aspire and ASHRAE. We all know that if you give CC from day 2, there will be increase in the number of recruiting follicles. If you give CC from day 5, it will only increase the number of follicle, increase in the size of recruited follicle. So if you want more follicle, then you have to give CC early. If you want to give less follicle or monofollicular growth, better to start CC on day 5. So fantastic view on IUNI. Thank you, madam. We are here to give pregnancy to our patients, and our goal is not a twin pregnancy, is singleton pregnancy. For that, letrozole has got very good value, and all the presentation by Charmila madam, Sonal madam, you, everything is fantastic. Any question is there, Minu madam, on the chat box?
Questions, but can you reply in the chat box itself, Rakhi?
Yes, ma'am, definitely.
So thank you, madam, because we are running short of time. So we will jump on to the another presentation, and it is by Dr. Sonia Malik, Professor Sonia Malik. She is going to speak on monitoring cycles and luteal phase support in IUI, whether it is essential or not. So
Sir,
we have a CV of Dr. Sonia Malik.
is not there. Ma'am is unable to make it today, so Meenu ma'am will be taking the lecture.
Okay, okay. So Minu madam is today Sonia madam. Welcome, IFS President madam.
She is too मतलब बहुत ही उनका जो एक स्टेचर है that
Madam, Sonia madam is South End, so you are North End.
ऐसा बोल सकते
She has got South End Fertility Center, so she is South End, you are North End. So, dice is yours, and now camera is yours.
Thank you very much. Thank you very much. Okay. All right. So I'm sharing my screen, and so I hope my screen is visible, Srishti.
Yes, ma'am. Yes, ma'am.
So I shall be talking. Actually, I can finish only in 10 minutes because everything already is covered very beautifully by Sonal madam, by Dr. Charmila and Rakhi. So I will be just little bit will talk about a bit of follicular monitoring and whether we need to give any luteal phase support in IUI cycles. So when I was the chairperson of FOGSI Imaging Science Committee, my thing was that every gynecologist should be able to do a decent pelvic ultrasound. It's a tough journey, tough road, especially for the senior ones who did not have an exposure to ultrasound machines when we were in medical college. However, for the younger generation, this road is much smoother. The patient is much more comfortable in a gynae clinic And we as gynecologists are also more comfortable doing a transvaginal sonography as compared to the radiologist. Time management is much better. Rakhi beautifully explained when to give the SCG injection, how much SCG to give, when to give the HMG injection. So all that, if we are doing our own ultrasounds, then we can manage it there and then. Otherwise, patient may call you at 8 o'clock in the evening or 9 o'clock. Now my radiologist has said that now the follicle is XYZ and you need to take the injection, and then you have to arrange for the IUI as well. So whenever we are monitoring for follicular monitoring, only one point I would like to add here, that especially when we are coming very close to the ovulation, we do not use jelly, we use normal saline. So we take normal saline in a syringe, because jelly is thoda sa, it becomes messy. So then, and we tell them, okay, today or tomorrow you should have intercourse. So sometimes that can also, it may also obstruct the passage of the sperms. That is also a possibility, especially when we are trying for a spontaneous conception. So all this is very well covered. I will not go here. Only thing is, if you are thinking that there could be a polyp or it could be a thickened endometrium. So what we do at our center, we keep an IUI catheter. So we take a little normal saline and just push it in transcervically. So immediately you can see if it is a polyp, you can beautifully see that it is floating here, and then your life becomes much easier. Or we can call the patient during her menstrual cycle. And we can also put a color Doppler to see if there is a single vessel supplying to the polyp, and that will also help us in making our decisions for our hysteroscopic polypectomy. For adenomyosis, whenever we find one wall thicker than the other, think of adenomyosis. And then, of course, there may be other features of adenomyosis which may be seen. Endometriomas already discussed. Dermoid, the bag full of balls. If you see some bag where a small, big, all sizes of balls are there, think of dermoid. That is again on ultrasound. So when we are doing a sonography, look at the iliac vessels. So medial to the iliac vessels are the ovaries. Okay, in a normal ultrasound, you don't see the fallopian tubes. However, if there is a tubular structure between the iliac vessels and the ovary, think of hydrosalpinx, pyosalpinx. That also sometimes it could be ectopic pregnancy. Fibroid mapping, very beautifully already taken by Dr. Sonal. Isthmosele, whenever you have a patient of secondary infertility with a history of previous C-section, or even otherwise any patient with previous C-section, look for isthmosele. Why? Because then our eyes get tuned to looking for isthmosele when we really have a patient with previous C-section who has postmenstrual spotting, bleeding, foul smelling discharge, or even secondary infertility. So whenever we are doing a baseline ultrasound, so what we do see on baseline ultrasound, now this is the day 2. Day 2 pe we see the antral follicles. So suppose I see 4 antral follicles on one side and 4 antral follicles on the other side, 3 or 4. So I know that she has probably a good ovarian reserve. Now, as these follicles are growing, now these are like the soldiers which are kind of recruited at the border. Out of them, one will become the captain. So one will grow in size. The one which is growing in size will also produce estrogen, which is a growing follicle. This estrogen will cause a negative feedback, and then the FSH will stop coming from the hypothalamus, pituitary. So now there is no FSH coming, but this follicle is an independent follicle and it will continue to grow. And the smaller follicles, because there is no FSH coming, they will undergo atresia. Now, this graph is very, very important, especially for my junior colleagues here, for 2-3 reasons. One, that sometimes we want to add HMG, like Dr. Rakhi said, we can add HMG, mild stimulation. So when to add HMG? If we add it over here on day 2, then all these follicles will grow. So we will exploit this in a IVF cycle. However, in an IUI cycle, we will start HMG when we see one or sometimes two dominant follicles, so that we have only that many oocytes for the IUI. Suppose we want to add estrogen, the thin endometrium, every time, 2 times we cancel the IUI because the endometrium was not growing very, very well. Again, when to start the estrogen? So once we already see a dominant follicle, 14, 15, 16 that is when, even if we start the estrogen, the negative feedback will not impact the ovulation. The third thing is, suppose patients sometimes come and say, doctor, last time the doctor did IVF for me, they retrieved 10 oocytes, and now today you are telling me that you might get 8 oocytes. Are you reducing my ovarian reserve by doing repeated IVF cycles? I have been asked this question even by the gynecologist coming for IVF to my center. So we can show them this diagram, that we are only harvesting the follicles which would otherwise have undergone atresia, and it will not going to reduce your ovarian reserve. So when we are doing the monitoring of the cycle, we see the dominant follicle grows 1 to 2 millimeter per day, and as the dominant follicle grows, the smaller follicle number and size both reduce. Again, Rakhi already mentioned, very important to catch the LS surge. Now, LS surge mein you will see a sonolucent halo, you will see a cumulus here, there may be increased flow, color Doppler dalenge to increased flow, and we may find some these secretory changes in the endometrium. Now, why should we know when is the LS surge coming? Suppose we have already given an HCG injection, then we can do IUI 36 hours later. However, suppose the patient came on Saturday, you were planning to give HCG on Monday, she comes on Monday, and this is the finding on Monday. That means her LS surge is already come. So even if you give HCG, her follicle will rupture before that, because her endogenous HCG, endogenous LH is already raised. So in these cases, what at our center we do, we do a urine LH test. So it comes as an iSure kit. If the urine LH is positive, you can also do a serum LH, that is also, but the report does not come very fast. So if the urine LH is positive and it is going with your ultrasound findings, then do the IUI either on the same day or the next day. So you will get better results. So when do the ovulation happen? Many patients come and say, doctor, मेरा follicle rupture ही नहीं होता है. Why do we think that? Because उनका ultrasound is done exactly 36 hours after the HCG injection. And there are many publications to show that the ovulation may happen 38 hours, 40 hours, 42 hours also after the injection of HCG. So we can wait and repeat the ultrasound again in the evening. That is one possibility. Second possibility is, if she has a history that the ovulation did not happen in the last cycle, before giving the HCG, we can do the E2 values. So per mature follicle, it is 150 to 200 picogram per ml. So if that is the E2 values and you have given HCG, then that is a good follicle that you are looking at. Then suppose I get a patient on day 21. So uska endometrium is looking like this. This is how the corpus luteum is looking, infertile couple. So I can say that ovulation probably is not a problem with this couple. She has regular cycles. This is the finding on day 21. So this has a corpus luteum and she has a secretory endometrium. So these are the positive points for the ovulation. Then we also have to look at the endometrium. How is the endometrium? Again, we can grade the endometrium. So this is grade A endometrium. How do we measure the thickness? From outside to outside, always at the widest area of the endometrium. So that is how we measure it. So this is grade A, grade B, and grade C. And this has got a better negative predictive value. So suppose आपने IUI किया, or maybe even embryo transfer we have done, and we find that this is how the vascularity on color Doppler, and we find that she did not conceive. Then we go back and see how was the endometrium. So we can tell, because the endometrium was not so good, that is why she did not conceive. Sometimes we may get a pregnancy 6 endometrial thickness, but still we got a pregnancy. So we should not start jumping, because these are the patients who have a very high incidence of early pregnancy loss. So that also point we have to keep in mind. Then what is the troubleshooting? Suppose हमने day 6 or day 7 we have done an ultrasound and we find a large follicle. Is it a good follicle? Is it a bad follicle? So sometimes we may find this 6 on day 6 or day 7. We can do the E2. E2 will not correlate with this follicle, or ignore this follicle, and maybe there is another follicle lying over here, which is like 10 mm or 12 mm follicle with a good color flow. So if we follow that other follicle, and if we have to give HMG, we give it as per the other follicle. And this follicle may sometime persist on day 2 of the subsequent cycle. So this is just a nuisance value follicle. Nothing needs to be done about it. Another thing is the luteinized unruptured follicle. Now, I practice in the city of Pune, and very high-tech IT people, they do their iSure LH test at home, and then they plan their pregnancy. But when they come to us that pregnancy is not happening, iSure is coming positive, what we realize sometimes that, especially in patients who have some mild endometriosis, some PID, that there is a LH which is positive, but the follicle is getting luteinized, but it is not rupturing. So these are more of unexplained infertility, because everything seems to be fine, but she is not still conceiving. So we have to keep in mind the possibility of a luteinized unruptured follicle. So how do we treat her in the subsequent cycle? I think this is the only patient where a little bit of down regulation, we can give her antagonist when the follicle is 14, 15, 16 mm in size, along with the gonadotropin injection for 1 or 2 or 3 days till we get a follicle of 18, 19 mm, and then give a trigger with HCG. Believe you me, we get excellent results in these patients with antagonist along with the gonadotropins. PCO patients, again, I think Dr. Rakhi already explained, we start with low dose 37.5. Why? Because again, as I said, one follicle, we want the one follicle to grow. Wait for 5 days. After 5 days, we repeat an ultrasound. If we find that follicle is growing, then we continue with the same dose. However, if there is no recruitment of a follicle, then we increase the dose to 75. Again, wait for 5 days and you do the ultrasound. So this is how we can monitor in the PCO patients. Again, this I think is already covered, so I will not go for all of this. Okay, just excuse me for a minute. All right. So, whether to give corpus luteum support in an IUI cycle, that is always a question mark. So there are many studies where they have shown. So two things we have to keep in mind. This patient has her own corpus luteum. This corpus luteum is secreting progesterone. So in an ideal circumstance, if we think logically, even if we don't support her with progesterone, there should not be a difference in the pregnancy rates. However, when we are giving the progesterone to these patients, especially if we have used antagonist, so then we are giving a support in the corpus luteum phase. Also, the progesterone has a good immunomodulatory action. So in patients who have a previous history, कि उनके 3 pregnancies हुए but they had a pregnancy loss. So in those patients, I think it is a good idea to give them progesterone. Now, what is the FOGSI statement on using micronized progesterone or dydrogesterone? Both they said we can either use micronized progesterone.
Sorry to interrupt.
Time is over.
You can conclude, yeah.
All right. Or we can, this is the last slide actually. So we can. Yeah, so we can either use dydrogesterone or we can use micronized progesterone, especially in patients who have a secondary infertility with the history of recurrent miscarriage. So we need to monitor these patients whenever we are doing IUI. Very, very important, both follicular and endometrial monitoring. role of estrogen in selected group of patients, when to give antagonist, when to give HMG, troubleshooting, and timing of the IUI. So thank you very much for patient hearing. Thank you.
Thank you, Binu madam. From today, now you have got one additional degree, that is LMF, last minute faculty.
No, Madhuri madam was also ready to talk. So
Madhuri madam had prepared this presentation within 1 day. You had prepared this presentation within 15 minutes. So thank you.
I had told her that I can also give the talk. There was no issues.
Yes, ma'am.
I would have
Madam,
also.
you are encyclopedia, madam. We acknowledge you as an encyclopedia of gynecology. We have to just press the button play. Then will be all the presentation will be there with you, madam. I have got legacy of
That is
lots of
because I have more than 800 to 1000 presentations.
Yes, madam. We know. You have got full library. So, so many times you have got the degree of LMF, but today Minu madam is right person to grant this new felicitation of degree. Last minute faculty. Thank you very much for taking thorough lecture on this monitoring of IUI cycle. And I'm very grateful to FOGSI that you had mentioned 2015 FOGSI position statement. And I'm one of the contributor of that FOGSI position statement. So thank you very much for
So I
projecting
just
this.
want to make a point over here. So if you look at the evidence,
Yes.
so if you are giving oral ovulations, basically there's no need to support the pregnancy but there are several papers and even the Cochrane review has come saying that if you're using gonadotrophins for ovulation induction and IUI patients, then you must support them with progesterone. But in patients wherein you're giving oral ovulations and you're having repeated failures, probably you should do progesterone 7 days after ovulation. If the levels are less than 15, then probably this is a candidate where you need to give progesterone for luteal phase support. Though it is said that there's no necessity, because it has been seen that luteal phase support can be seen even in patients who are given clomiphene citrate or also in a natural cycle, though the incidence is less. But the mechanism for luteal phase defect in a natural cycle, in a clomiphene stimulated cycle, and in a gonadotropin cycle is totally different. It's also said that HCG at times can cause luteal phase defects after giving the trigger. So probably through the LH mechanism. So therefore, probably whenever we are giving LH, HCG also for trigger, you should give luteal phase support.
And madam, we all are born with progesterone. Progesterone is the hormone, nurture us. And our all mother might not have taken progesterone as a luteal phase support, because endogenous progesterone production. And whenever you suspect, you can nurture the cycle with additional progesterone if it is required. Thank you very much, ma'am.
Thank you, sir. Thank you. Thank you, Madhuri ma'am, for your comments. Thank you very much.
Thank you, everybody. Thank you for the chairpersons and the speakers for sharing their valuable insights and experience. It was an absolute privilege to hear to you all. And with that, we conclude our second session of the day and we move on to the last and final session. Before we move on to the final session, I would like to take this opportunity to extend my heartfelt gratitude to Meenu ma'am for providing me this opportunity. Ma'am has been extremely kind and forgiving. So thank you, madam. And we move on to the last session on a case-based discussion for ovulation induction. And I request Meenu ma'am to please call upon the moderator.
Madam, we must thank Susti for taking pain for making this conference successful, because she was working late night to give reminder to everybody. You had called me at 11:30 last night.
I was sending messages to everybody.
Yeah. So
And
he is hardworking guy, madam.
thank you, sir.
We were late in the night and I was not getting sleep also, because this first time I was coordinating with Srishti, but she's done a marvelous job.
She's done a marvelous job.
Thank you, ma'am. You're very kind, ma'am. I don't have much experience, but you've been very forgiving. Thank you so much.
Thank you. Lots of thanks, huge thanks to Dr. Sarita Bhalerao, madam. I am not seeing her here, but very cool, very nice, and a lot of support from her for this entire all these 3 days. So it's a privilege and an honor for me to introduce Dr. Sujata Kar. She is the moderator for this case-based discussion on ovulation. She is a gold medalist in both in MBBS, MD. She has been credited with the first IVF baby of Eastern Orissa, first laser hatched baby of Orissa, best IVF center in Orissa for last 2 years, Brand Icons Excellence Award for best IVF center again in Odisha, Pariksha Award for Women Achiever, Devi Award for Dynamism and Innovation. Many publications, 14 original publications, my God, wow, related to PCO and male infertility in PubMed. She's written many chapters.
Thank you. Thank you very much. But this is a very old,
Very,
thank you for your introduction. So
very
I think,
very suave, very smart, very intelligent, and
thank you so much.
gorgeous.
Thank
You
you.
are gorgeous.
Thank you. Thank you.
Yeah, you can introduce your panelists, Dr. Sujata.
Okay. So may I have, so thank you once again, Meenu and the entire team of ICOG for giving me this opportunity to conduct a panel. So my first panelist is Dr. Jairani Kamraj. She's from Chennai. She's a member of the and associate secretary of the World Association for Sexual. Her major part of interest is sexual medicine, and after that comes ISAR and interest in infertility. She's of course very active member of FOGSI also. She has got many medals and awards. So welcome, Dr. Jairani. My next panelist is Dr. Kundan Ningle. Again, ardent endoscopy and infertility lover. He's been the chairperson of FOGSI Infertility Committee, and he is currently the director of Nimriti Clinic. And he was awarded the second best research paper in NISAR 2018, NISAR 2019, and also in NISAJ 2019. He's the founder treasurer of Maharashtra chapter. Basically, he's extremely active member of FOGSI as well as ISAR and as well as IAG. And I welcome Dr. Dipti Gupta. She's the secretary of AMPOGS, immediate past secretary of GOGS. She is the FOGSI Quiz Master of West Zone Coordinator, co-convener of the Quiz Committee of FOGSI, and many such accolades. I can see that currently she's the MP ISAR Executive Committee member. Many papers. She's the winner of CS Dawn, so prize of AICOG 2022. So lots of accolades. Dr. Dipti, welcome to the panel.
Thank you, ma'am.
And then finally, I also have Dr. Neena Malhotra. She's a very, very close friend of mine. Is she there? She's the head of the department of the All India Institute of Medical Sciences in New Delhi. And again, she has many accolades. She has over 145 peer publications in a peer-reviewed journal. And similarly, many other awards to her credit. Her special interest is endometriosis, genital tuberculosis, and implantation failure. And finally, I also have Dr. Tejas Gundevar. May I have his? Okay. So today's panel, I'll just share my slides.
Consultant at Ruby Hall, IVF department, and very young, dynamic, and also does a lot of male factor infertility.
Yeah, just 1 second. Let me just open my
essay and a lot of good surgical work that he's doing.
Dr. Tejas, right?
That's right, yes.
Great. I hope all of them are there. So let's start off, but everybody is there. I don't see anybody. Meenu, everybody is there.
Dr. Dipti Gupta is here. Dr. Tejas is here.
I see. 1 second. Because, in as such, it's damn difficult to do a panel on the webinar, especially when you can't see who
Ma'am,
you're talking to.
we anyways have so many experts.
So I think it is going to be with
Right.
Madhuri madam, Meenu madam, everybody still around.
Absolutely, absolutely. So I think, let me just, 1 second. Just a little bit of introduction. I think a lot has been covered about ovulation induction, and we have about half an hour to cover today's panel. I can see Jairani now, and just a little bit of introduction on ovulation induction. Ovulation is, of course, a very finely orchestrated event. Each month, about 600 to 650 oocytes are destroyed. They undergo atresia for the sake of one dominant follicle that ovulates. There are many variables.
Share your slides, na?
Pardon me?
You not shared your slides.
I have not?
No,
Share
ma'am.
your slides.
Oh, sorry. I'm sorry. Is it there now?
Yes.
Yes.
Okay, sorry. Sorry about that. I thought I'd shared it. So ovarian stimulation, of course, one size fits all just does not apply. And there are so many variables, but patient is the main variable. There's so many different kinds of patients that each patient has to be considered as an individual entity. And then one has to decide your strategy for ovulation induction. So first case we can take up, I don't think we'll have time for more than one case. So I took up ovulation induction in an hyper responder, PCOS woman, because that is the commonest reason why we will need to do a ovulation induction in a woman. But then there are other indications also. We know that PCOS is the commonest, but we also need to do ovulation induction using oral ovulogens in unexplained infertility, in grade 1, grade 2 endometriosis, mild and moderate, male factor, and often while we are doing donor inseminations, mild stimulation. So there are many reasons, but today we'll just start with one case of a hyper responder, a PCOS woman who needs ovulation induction, and see how far we can go discussing this case with our panelists. So this is a patient. She is 25 years old. She is a case of primary infertility of 3 years. Her menstrual cycles are very, very irregular, once in 2 to 3 months. Flow is normal. BMI is around 30. She's moderately hirsute. She has some acne. And basic investigations, her ultrasound shows an antral follicle count of each ovary showing about 20 to 25 antral follicles, volume of close to 15 to 20 cc per ovary. HSG is normal, and a seminal analysis largely is normal. So she is first time come to us for infertility, and we know that we need to do ovulation induction for her because she appears to be a case of polycystic ovarian syndrome. Now, what tests would you like to advise for this patient? Can I start with maybe Jairani? You can answer that.
Ma'am, the tech team is just unmuting, ma'am.
You're muted. For a patient like this, whom I said is like overall she's okay, other than the fact that she's anovulatory, has very irregular menses, what are the investigations you will do for her, minimum investigations, before you start a ovulation induction? And second question is, will you advise a serum AMH for this kind of patient?
Ma'am, may I answer?
Yes.
So, ma'am, thyroid profile and prolactin is a must for all patients coming with subfertility.
Okay.
And looking at her profile, her clinical picture seems to be suggestive of PCOS. So definitely we need to rule out glucose intolerance and lipid abnormalities because she may be already suffering from or at risk for metabolic syndrome. However, AMH, I would definitely not do routinely for such a patient.
Okay. So in this particular patient also, you will
Can
not
I come in?
do
One
a
more
AMH.
investigation.
I'll ask Tejas. Tejas, what would anything else you would want to do?
So, ma'am, I think I would also like to add testosterone because she is mildly hirsute and she has acne. So,
What testosterone would you want to do?
total testosterone, ma'am. Total testosterone I would like to do.
But
to
if she
understand whether-
already has clinical hyperandrogenism,
Yes. So
Absolutely.
how will it help you in ovulation induction?
it
Or
would not. if testosterone values are on the higher side, then I think I would like to give her oral contraceptive pills for a couple of months and then start the ovulation induction before directly jumping to ovulation induction.
Okay, so that is the logic. Any other
Yeah.
panelists would like to comment on this? Or
I
Tejas,
thought
before we go
I-
on to Jairani, just 1 minute.
yeah,
Before
yes.
we listen to your answer. Dr. Tejas, what about AMH? You would not want to do an AMH?
No, ma'am, I don't want to do an AMH because I don't think so it changes my management, because though even if the AMH is on the higher side, it is anyways ovulation induction has to be done. So the dose or whatever will be decided based on the BMI. So AMH at this moment of time doesn't help me.
Okay. Jairani, what is your take on this?
Regarding the testosterone, I differ with Tejas. I would like to go for a free testosterone instead of a total testosterone, because that is one important thing that we can do. But already she has a hirsutism. There is no point in going for a testosterone, which doesn't desire any role for the induction of the testosterone level. One thing I would like to add on to it is a estimation of 17-hydroxyprogesterone, which is always the important step which we can do, because many times this could be one reason for her type of a PCOA, which may have an additional information regarding the adrenals, whether they have any problem regarding ovulation. Whether we can add up a dexamethasone in the ovulation induction, which will give us an idea whether this has an adrenal component, because she is a exotic, she has a thick PCOD, plus she has all the symptoms of obesity, BMI more, and all the hormones more for her PCOS. So it's better we check her regarding the adrenals also, which also can be associated with that, which may help us to plan this, induction with steroid
So
adding.
if I
So
may
basically,
summarize.
Sujata, I would just want to say
Yeah,
that
yeah,
no
Madhuri.
role of doing free androgen. If at all you have to, if there are no clinical features of hypoandrogenism, then only you need to test for biochemical hypoandrogenism. And what you need to do is a free androgen index, wherein you do a total testosterone, which is divided by SHBG and multiplied by 100. So only you need to do that. AMH is most important because that's going to tell us how the patient is going to respond. So it has been seen, though you have a high MH, these patients are at an increased risk of OHSS, whereas those patients who have a very high AMH, as seen in this patient, basically they are more poor responders because we know that they block the recruitment of the pre-antral into antral
So
follicle.
we'll just come to that, but I agree with what Madhuri said. But let me just summarize as to what our panelists said. I think all of them have a point to make.
Ma'am, one more
Now,
thing on the
where
progesterone, ma'am, one more thing on the progesterone, what madam was saying. I think we are talking about late onset congenital adrenal
hyperplasia. Yes.
Yeah.
That is
And
not required unless
yeah,
you're
means I
suspecting.
think the most important indication would be a perimenarcheal hirsutism. That is the patient, that is a group of patient where doing a 17-hydroxyprogesterone is going to help you.
Correct. So if I may just summarize what you all said. So I think, yes, number one is there is no need to do testosterone biochemical hyperandrogenemia, either for the diagnosis or for prognostication or for deciding your ovulation induction drug. We basically don't need that. And if at all you're going to do, a total testosterone may be indicated if you do not have clinical hyperandrogenism and you want to diagnose PCOS. Having said that, the point that Tejas made is that if there is high testosterone, he would want it to bring it down using oral contraceptive pill and then start an ovulation induction. That has a point, and it used to be followed by many clinicians many years, for a couple of years back, and I'm sure that there are many like you who like to follow that also. However, after lots of studies and lots of publications, we now know that preconceptional care is better achieved by weight loss, exercise, and lifestyle changes, which is as good as an oral contraceptive pill. And initially, people also used to think that LH is high, and to reduce the LH also, we should give a dose of a course of oral contraceptive pills. But this strategy has not stood the test of time. So many people will not do to reduce the testosterone levels. Now, congenital adrenal hyperplasia, the patient, I think those who will show up with very severe forms of hirsutism and all that, we may consider doing, like Jairani said. But there is a set of tests that very often we think of doing. And if initially as a diagnostic test, 17 progesterone, hydroxyprogesterone is part of your diagnostic armamentarium, you may consider if the patient has severe hirsutism, etc. But AMH, the point that we are trying to make here is that it has a point, from the point that you can decide or it will give you an idea about how well she is going to respond to any kind of ovulation induction, whether it is oral ovulogen or it is gonadotropin or anything like that. That is why now I have started doing serum AMH levels for all patients of PCOS, or at least severe PCO phenotypically, who require ovulation induction. So that is why I did an AMH, and her AMH appeared to be very high. Now, the
one next more thing, like what you are talking about AMH, I think the same story we can understand from a sonography. If the stroma is more and the follicle...
No, that does not always correlate with stroma. It does not always correlate with stroma. So and of course, I agree with you that the guidelines still have not told you that doing an AMH is mandatory, either for the diagnosis or for prognostication. But as slowly we are learning more and more about PCOS, and we are doing a lot more research also in couple of centers like mine. So we prefer to do a AMH, but I don't want to give out the message that AMH is an absolute must for the diagnosis. But for patients like this, wherein you are finding it is very abnormal, it might help you in knowing that she is not going to respond well to ovulation induction. So how do you want to induce ovulation for her? I can start each one of panelists just quickly. Oral ovulogen, what would you give? Clomiphene or letrozole, and any adjuvants that you would like to ask. Quickly, just what would you do? Yes, Tejas.
Always, as you rightly pointed out, we will start with her lifestyle modification, which is very important.
Yes.
That will definitely help her for a better response. Definitely 5 to 10% of her weight loss will definitely help her to improve in all the parameters of the ovulation induction. So first step of treatment is first lifestyle modification. She's just 28 and her BMI is more than 30 and she is very young with a very high AMH. So ideally, best we have to advise her about the lifestyle. And we can check
ovulation induction, how you will plan? What is your first line? Because she's not had any treatment before.
Yes. So the standard drug which we always advise is the letrozole, because that's the first line of
what will be your dose in this patient?
So definitely she's obese. Her BMI is very high. I'll like to preferably, I will start her with 7.5 to 10 milligram per day as a dosage.
You will start with 7.5, is it?
Yeah, definitely. She has a very
what about
high
Tejas? Let me take the opinion of the other panelists. Just tell me the dose. First, tell me whether you will start with...
5 milligram for 5 days. I would start with 5 milligram. She's never had an ovulation induction before.
Yes.
So the first cycle. So let's go with 5 milligram. I think that should also be enough for her.
And letrozole will be your first choice?
Yes, absolutely. Letrozole.
Any adjuvants you want to add?
Metformin.
You will always add a metformin?
I will. In this patient,
because her glucose tolerance is normal.
Yes, ma'am, glucose tolerance is normal, but then in that case, it will be adding a metformin will only improve the insulin sensitivity and it will only aid in the ovulation induction process. So I would still want to add metformin.
Dr. Deepti, what about you?
Ma'am, since this is a first cycle, I would stick to lifestyle modification, weight loss, and 5 milligram letrozole.
So you will not add a metformin?
Not immediately.
Okay. What about in this patient, once you induce ovulation, will you advise for a timed intercourse or you will go straight for an IUI?
Timed intercourse.
Everybody agrees with that?
Yes.
No, I will not advise timed intercourse. I will advise her regular intercourse, because if you put a timed intercourse, she will go in for all the sexual dysfunction and she will end up only with an IUI. So ask them to have a regular sexual intercourse. That will help her for a better fertility, both from the semen parameters as well as the mental parameters.
Right. But I think Deepti, Tejas, don't you think that she is PCOS? We need to monitor her and see whether she is actually ovulating or not.
Ma'am, monitoring and rupture is obviously an integral part of any stimulation.
Yeah, absolutely.
Yeah.
Follicular monitoring. Yes, yes.
I think it goes, it should be implicated and implied for that if we are inducing any patient, she has to be monitored.
It is also, the monitoring should start from the day 2, because many a times people start from the 10th day, which is very wrong. Before we start an ovulation induction, ideally we should do a basal scan on the 2nd day, check for any previous prior luteinized unruptured follicle or a residual cyst, which is very important, especially for the PCOS. Otherwise, they will go for hemorrhagic cyst formation, and that will definitely hamper your ovulation response. So all this says to start from the day 2 of the basal scan, which has to be followed from the 10th day of the ovulatory monitoring. Definitely. Yes. Always it should be monitored.
Of course. So one of my panelists said she'll go only with letrozole. My other panelist, Jairani, wanted to go with a very high dose of letrozole to start with, but Tejas wanted to add letrozole, metformin, both. None of you will ever consider a clomiphene citrate and metformin?
Ma'am, for me, letrozole will be the first drug of choice if it's a case of PCOS. And we're talking about ovulation induction, basically anovulatory infertility. In that case, I think letrozole will be the first choice.
Okay. So clomiphene and metformin also, according to recent publications, is a good choice and give us as good a result as letrozole. I will just quote some. We will not have time much to go through these, but there was a very good IPD meta-analysis that showed us that we can personalize, because ultimately ovulation induction is about personalizing to individualizing, or rather individualizing to each patient. So just like we had classical symptoms of what were the features of a CC resistant PCO woman. We have read this right from our MBBS days. Now we also know what is a feature of a likely letrozole resistant PCO woman. I think one of the primary considerations that when you see a patient, of course, obesity, hyperandrogenism, all this is acanthosis, hyperinsulin, this is features of insulin resistance, and this will be resistant to clomiphene as well as to letrozole. But specifically for letrozole, if you have high androgens, or if you have high ovarian volume, then those are the very high AMH. Those are the women also likely to be resistant to letrozole. So this was a very fantastic study, 2 or 3 that I have quoted, where they said we could individualize. So our patients who have high insulin, or rather who are showing features of hyperinsulinemia and insulin resistance, they will respond better or as good as letrozole to clomiphene citrate and metformin. And those women who have high testosterone level, I mean, when you're comparing, if you're doing a test, then they are likely to respond better to testosterone. The point of putting this point here was that we still have a role for metformin and clomiphene citrate, specifically in our Asian Indian group, where we have a lot of inherent visceral obesity and we have a lot of insulin resistance. Metformin and letrozole, like you started with, first choice also is very good, but as a second choice also, or even as a first choice, clomiphene citrate and metformin is also as good as letrozole. And it has been shown now that women who have very high letrozole, AMH levels, I'm sorry, or rather AMH levels more than 4.5, we really don't have an absolute cutoff, but this is one of the papers that I'm citing. They are likely to be resistant to ovulation induction in any case. Okay, so a little bit about metformin. So, since Deepti, you did not want to give metformin to this patient to start with. According to you, which is the category of patient whom you will give metformin while ovulation induction?
Ma'am, PCO women who have had previous poor response or resistance to oral ovulogen, or women who have, yes, or who have glucose intolerance.
Okay.
those are probably the subgroup of women who I would like to consider adding metformin.
So obesity and those things will not count. I mean, they have to be resistant for you to show resistance, then only you will give.
Can I say something here?
Yes, yes, Minu and then Jairani also. What is your take on metformin?
For me, any patient who comes with the symptoms of PCO, infertility, obese, I will start her on metformin there and then start with the ovulation inductions from day 2. That is,
I think yes.
No, but
I
that
think
is a personalized
I
thing.
agree with
But
Minu.
the evidence doesn't
I,
say
I will
that
also
you should start
consider the same.
metformin to all patients of PCOS. There is no evidence for that. You have to choose your patients in whom you will start metformin.
Jairani, would you like to say?
Yeah, I will always start with metformin, especially in obese young women. With even if we never go in for her, GTT or any glucose intolerance testing. Instead of that, just the obesity weight loss by the metformin will help her to improve her response to the ovulation induction.
So see, where the evidence is concerned, like Madhuri brought that up, there is good evidence, enough evidence published which shows that clomiphene citrate plus metformin is superior to clomiphene citrate alone for first-line ovulation induction in PCOS. It is there. Of course, again, having said that, we usually choose and decide whom to give. There is not enough evidence published in literature as of now to say that letrozole plus metformin against letrozole alone. And this is for you, Tejas, because you like to, let me also say that I would do the same thing what you said. I would also add metformin to this patient usually, but letrozole plus metformin against letrozole alone as first-line ovulation induction drug in PCOS women has not been proven. So there is no evidence supporting that aspect. We need to show that. Anyways. So what about inositol? This is a multi-million-dollar question.
Inositols again are insulin sensitizers. However, if I do have to give an insulin sensitizer, then I would prefer to give metformin, not inositols.
Only patients who are intolerant.
Inositol is not there in your prescription at all for PCOS women for ovulation induction.
No, we'll give for only patients who are not tolerant to the metformin, because many times the patient may have a lot of puking, vomiting, loose motions, and sometimes they may not
That
tolerate
is a good
metformin.
indication. Yeah, maybe.
One thing. And
only thing is we don't have enough evidence to support inositol for ovulation induction. We may have for reduction in metabolic parameters.
Yes.
But we don't have much for ovulation induction. What about others, Minu? Do you give inositols for ovulation induction?
Combination. I don't use only inositol, but I use a combination of metformin with
Yes, there is a combination now available. Of course, I have 0 prescription, so I don't know. Madhuri, do you prescribe?
I don't prescribe inositols because one is basically they're just nutrients. They are very expensive, and as it is, the patients who are undergoing infertility treatment are spending so much of money. So I don't believe in making them spend more, wherein really, I mean, its efficacy is not proven, because most studies are having small number of subjects, and all the studies have come from Italy, where it's basically manufactured. So, and I had done a very small study which included about 60 patients. So, wherein we did not give anything for ovulation induction, but we looked at all the parameters, and what we found is there was not much difference in the hormonal parameters of that patient, nor did her cycles become regular.
Right. Dr. Tejas, is there any place of inositol in your...
Ma'am, as Minu ma'am said, I usually give it along with metformin. And it's a combination that I give, and that too only in patients where ovulation induction is being planned. That's it. Apart from that, I don't.
Okay, fair enough. So now, I think Jairani will have the last laugh because I gave this patient 5 milligrams for 3 days, 5 days, day 3 to day 7, along with metformin 850 twice a day. And of course, some lifestyle advice you have to give them, but there was no ovulation. What to do next? Jairani, you have already given the answer, so I'm not asking you.
in the same cycle, if there is no dominant follicle, if the endometrium is not very thick, you can increase the dose and make it 7.5 milligram and continue.
Okay. So now we increase to 7.5.
Yeah, and step up in the same cycle. That's one thing. Apart
Step up
from
to 7.5 or more.
yes, 7.5 is enough.
So
7.5.
you'll give it for another 5 days. If you feel that there has been no response, endometrium is thin and etc. etc.
Yeah.
So Deepthi,
Ma'am,
you
I
said,
would like to call my patient back before she reaches day 20 of the cycle and then add step up the
no,
dose.
but what I meant by this is that we followed her up for a long time. So
Long
I've
time.
seen very often day 15, 18, 20 also they start developing.
Yes,
it can
and counseling, ma'am. You know, we need to tell them that they may take a little time to ovulate and for the follicular response.
Okay, so 7.5 is what you all will go up to. Any other choices? Now also nobody wants to give clomiphene.
Ma'am, low dose gonadotropin.
One option is
You want to go to gonadotropin from now, Deepthi?
No, ma'am.
No.
I think, ma'am, one more thing that can be done is obviously, as you said, adding a clomiphene, or the another thing that you do is an extended letrozole protocol where you keep giving letrozole. You can continue with 5 milligram of letrozole till you have a dominant follicle. And at times you will see wonders where you will have a dominant follicle. If you keep giving letrozole for 7 days, 10 days, you just keep giving it.
Yeah, no, we can't keep. Do you think we can keep giving it like for many days?
No, we cannot, ma'am, because of the mechanism of action.
Yeah, I would not agree because I mean, physiologically,
I will not continue. I'll ask the patient to come for the next cycle. Give her a progesterone withdrawal and then ask her to come because she will not be very happy to continue. She will have a lot of questions
no,
to
that
ask.
that is a separate matter, Jairani. Of course, either you could continue in the same cycle if you feel there is nothing, like Tejas said, or you could get her a withdrawal and start fresh in the next cycle
at a
with
higher
either
dose.
7.5 for 5 days, or you could give her an extended for 10 days. But what I said is that I don't think we can keep giving her for 15, 20 days, 2 weeks, 3 weeks. Can we do that? Is there any publication on that?
I don't know, ma'am. I'll have to search if there is. But
no, I haven't seen any publication.
Ma'am, also,
No
I have
evidence
query.
for extended dose. There were papers published for 7.5 milligrams, but then when they did an RCT and they compared 7.5 with 5 milligrams, they found that there was no advantage of giving 7.5 milligrams.
No, there's no advantage. But people who have failed
the
with
maximum dose, what you have to
Having
give
an
is 5
ovulation
milligrams.
induction with that, then what do you do? If you're not able to induce ovulation with 5 milligram dose.
No, what Madhuri is saying and what you're saying are two different things. So if she does not respond, there's no doubt.
Try
5 milligrams.
clomiphene with metformin in this patient because there are many
you
patients
could do
who don't
that.
respond to letrozole but do respond to clomiphene citrate.
Yes. But extended letrozole 10 days is what I have seen, Tejas. So I think that is one choice. Any other choices?
I have a query
What do you know?
regarding.
Pardon, tell me, Deepthi.
I have a query regarding the step ladder letrozole
stair-step
induction that
protocol.
people talk about.
No,
There are
that
very
is
few
all by the
publications.
pharma companies. There is no evidence for it.
No evidence, right?
No. These are published protocols.
Yeah, they are published, but they are not RCTs.
They're very small studies. They are
No,
very
and they're
small
not
studies.
RCTs. For evidence, you should have an RCT.
I agree largely. They are all
what
very
percentage
small,
of evidence in
small
reproductive
studies.
medicine will have an RCT? What percentage of evidence in reproductive medicine?
Yeah, so
will have an
whatever is
RCT?
there, no, they're almost
That's fine. We are not saying
have
anything.
RCT.
We are saying that these are the different possibilities.
No.
These are the different choices that one can take. Stair step is also a possibility that has been published. Now, that is not the standard. We are not saying that this is any kind of a guideline. We are saying these are the options one can take before moving on to something bigger like a gonadotrophin. So, you can do that. You can do a stair step is like you start with 2.5, 5, 7.5 and 10 for 4 days. You can give a single high dose 20 milligram. Now, this is not any guidance. This is just, these are the various things that people have done. You can add letrozole to metformin that we have already discussed. There are papers to suggest you could add both together. From day 2, you add clomiphene and then you also add, because they will act at 2 different places, and that could also work. So these are a couple of things that you could do. Now, that was about, of course, for that particular patient that we were discussing, I gave her 7.5, which is my favorite thing to do. She ovulated, and I think in 2 or 3 cycles, she got pregnant also. So 7.5 is what I did for that cycle. Now let's discuss a little about lean and obese. Do we have time? Meenu, do we have some time? Or do we stop? 2 minutes
Yes,
more.
ma'am.
Okay.
2 minutes.
So I think quickly, my panelists can start by saying ki how lean and obese are different and how your approach to ovulation induction will be different in them. For example, Tejas, if it would be a lean, would you add a metformin?
No.
You
Only
wouldn't add a
there is,
metformin.
yeah, I would not.
Instead, would anybody add inositols?
No.
Instead
Yes.
of 5 milligrams, will you give a 2.5 milligram? Each one of you
No.
can answer this.
No. So we
No?
can give, we can even give a metformin. It's not a, the obesity matters. It is mainly the insulin resistance that she has, because the lean PCOS, they have more insulin resistance compared with obesity. So
Sometimes, yeah.
definitely
If a lean patient has glucose intolerance, you'll add a metformin.
we have, yeah, we have to
But
give
my
her.
question is, will you not then start her with a 2.5 milligram letrozole?
No.
I am fine with starting.
I'd
if
start
it's
2.5
lean,
all
and I
the
would have
time,
no
all the
problem
time for
starting
a
with
lean patient. And I'm sure all of you are also aware that in our country, the DCGI has approved only 2.5 milligrams as a ovulation for ovulation induction. We are not approved for 5 milligrams. So why will you not start with 2.5 for a, let's say, a 17, 18 BMI patient?
I am fine starting with 2.5 milligram. I have no issue.
So that's what I wanted to bring out. I do that very often. Anyway, these are some, I think, so since, and what about even
Also,
clomiphene?
one more thing, Sujata, that people should take home message that even lean PCOS are insulin resistant.
Yes,
One
yes.
has to identify insulin resistance in these patients, and then
Yes.
metformin should be added. It's not that only obese are insulin resistant. It is both lean and obese which can be insulin resistant.
Of course, yes.
Because
yes.
the basic problem of the chronic inflammation and oxidative stress is equal in both the lean as well as the obese PCOS. The basic pathology of a PCOS. Nowadays, we come across with a lot of gut dysbiosis, which is a cause for the PCOS. They mainly focus on chronic inflammation and oxidative stress. And that is even equal among the lean and the obese PCOS. So we should be more concentrating on those type of a management, especially both for the lean
So
and the...
I think we can stop our discussion here with a very last final question. In a yes or no, is there a place for ovarian drilling in your practice? We start
Yes.
with
Yes.
yes. They just said yes. Jairani, yes.
Very minimal, very minimal.
Very minimal.
Limited space. Limited space.
Limited space. Which is the patient you will choose?
Ma'am, if she has another existing pelvic pathology, which warrants an endoscopy either which ways, or she's extremely resistant to, all these modalities of oral ovulagents plus insulin sensitizers, and requiring very high doses of gonadotropins, probably then.
Anyone? I think because we have no time to discuss this, do you want to change anything?
Very controversial.
Very high LH.
Only
Very high
resistant.
LH is a very good point.
Very high LH is the one, and very thick cortical tissue with more of follicle resistant to the stimulation, we advise. And a previous history of a hyperstimulation OHS is when we are planning for the second cycle, we have to be very cautious in dosing. In addition, if we
So
can
you will also do sometimes to reduce complications of IVF.
Yes.
Yeah.
Okay.
Ma'am, I would like to differ, and I would
yeah.
like to say the only indication will be if there is resistant to ovulation induction in whichever way, either oral ovulogents or injectable ovulogents.
Also some other conditions like she will be lean and she will be very less duration of infertility. Is that not very important? So we can't be doing, I mean, they're very clear-cut
When you
criteria.
are doing the laparoscopy for any other reason and she has PCOS, and you should not do more than 3 punctures, because it is still said that gonadotropins are the better second option than an laparoscopic ovarian drilling. And
yeah, but here, Madhuri, if I may...
lean PCOS, and also those having high LH as well as androstenedione levels. So these are the group
so
of
high LH, lean, less duration of infertility, all that is fine. And of course, CC resistant, all that. You'll do only... But I don't agree with either Madhuri or Deepti about the fact that you can do a incidental or a LOD just because you're doing a laparoscopic
no, only if she has PCOS.
or anything else.
No, only because if she has PCOS and you're doing, So you can just do, so it's going to correct her
So
hormonal
I
imbalance.
feel that initially, even in in international guidelines, it was given, but now they have withdrawn it. So a opportunistic ovarian drilling is not the message that we should be giving. That is not never to be done. If you want to do ovarian drilling, you have to have planned it beforehand. Okay, this patient needs ovarian drilling. Along with that, I am also doing laparoscopy for whatever. Very often PCOS is associated with endometriomas, etc. We know that. So that, but opportunistic ovarian drilling should never be done. Ovarian drilling has to be planned properly, choosing the patient properly, and then we should be doing. So thank you very much for this fabulous opportunity. And hopefully we'll have the chance another time to finish this discussion. Thank you so much.
Thank you, ma'am. Thank you for a lovely panel
Thank
discussion.
you, thank you, thank you.
What a wonderful panel.
Thank you, ma'am.
Very, very, very nice
Very
discussion.
nicely conducted.
Take home messages for all the delegates and the faculty who have, even I took, so all of us have taken so many messages from your panel discussion. Good cases that you put forward, and very, very good, both young and senior, the good combination of the panelists that we had.
Thank you so much. Thank you.
Thank you, Dr. Sujata.
Thank
So
you.
now we have a post test that you have to put.
Yes, ma'am. The team is putting it. The link is being put up.
Yes, yes, yes. And you were also.
Ma'am, the link is put up.
Yes, and there are some questions in the chat box. And Dr. Madhuri ma'am is already replying to all the questions. Thank you so much, Madhuri ma'am. And yes, and lot of positive comments for the panel. Dr. Sujata and all the panelists here. Thank you. Yes, so please put the post test. So for everyone, whoever has not given the test earlier, the pre-test, it is all right. You can appear for the post-test. And then once you have given the test, I will read out the answers for the test. Also, people who are asking for recording, this recording will be available on the ICOG website after 1 week. However, they are also asking for the PPT presentation, which you may ask the speakers directly, but
I don't think it's available on the ICOG website, because even for our lectures for the students, we don't give the PPT. It is.
Yes, PPT, I said,
It's not
but
given.
to have a connection with the presenter, you could ask directly and take it. That is a different thing.
Nilima, please post the link now for the post test. Nilima?
Ma'am, it's already there in the chat box.
Everyone karna.
No, the link is not yet
Not
posted.
there. It's not there in the chat box.
Not there in the chat box, Nilima.
It's not there.
Now it is there.
Now it is there.
Now it's
I request the participants to please stop typing in the chat box. Otherwise, the link will get lost in all those chats. The link has been put up again. Nilima, can you restart the timer for 10 minutes? It's already showing 8.5.
Yes, yes.
Vedika, if we get all submissions done, then we can even start before that time.
So congratulations, Minu madam. First day is over. So 25% tension has gone. 30%
33%.
will go tomorrow and 60% and another remaining 40% will go on day 3.
Thank you, sir. Thank you.
Thank you.
Thank you.
And thank you, ICOG. Thank you, Susti, for giving me opportunity to be with you. So thank you very much. Thank you, Madhuri madam, for your inputs. Madhuri Square is already gone. Thank you.
I'm there. I'm not gone.
Madhuri Patil madam is.
Madhuri Patil madam is there. Madhuri Patel madam has gone.
Yes.
So Madhuri Square, one is there. Madhuri Square has gone.
I like your sense of humor. You are always
Thank you, madam. Keep the audience live.
correct.
Thank you. So we can call this day off, Susti madam?
No, we have to discuss just 5 minutes the
Yeah.
result.
I think, Minu, those not able to do it, they should check their internet connection and the link, I
I have
think.
written that, madam.
All the others are doing. I mean, if they cannot do it, doesn't mean that, it's not working, na, the link.
No, ma'am, the link is working. We've checked, ma'am.
Link is, link is
that's what I'm
working.
saying. No,
The link-
no, but people, I mean, I think there must be some problem with their internet
Yes,
connection.
ma'am. They can try some other browser or some other device. Just copy paste that link in other device or another browser, please.
Hello.
Yeah. If you're using a Google Chrome, paste it in the Safari. If you're using Safari, paste it in Google Chrome. So that is why Meenu, I was saying that all lectures should be 20 minutes. In 15 minutes, one cannot cover things. So therefore, even when I made the program initially, I made it 20 minutes.
Right, right.
Because 15 minutes is not a time for, covering the end, even superficially.
Right.
Like in our students' lectures, we used to give 1 hour for each topic. You have to, if at all you're going to do a certificate course, the discussion part is most important.
Yes, agree with you.
Ma'am, I think the 10 minutes are done. We can, if you want, you can discuss the answers now.
So I shall, one moment.
I don't think we should discuss the answers today. We should discuss it on the last day because there's still others who will get the link and then they'll be answering. So they will answer all the questions. So I think we should do it on the last day.
Okay, ma'am.
I don't think we should do it today. Because you're still, they'll still get the link from the office and they'll answer. So if we discuss the answers, I don't think it's right.
Okay, ma'am.
Yeah.
Okay.
I think we'll see everybody tomorrow then.
So, okay.
I think Nilima or Poonam, whoever is there, you have whoever has logged in, probably you have everybody's this thing, details, and probably you can send them a link, or everybody who's logged in has given their email ID, so you can send everybody a link again. Whoever is not answered will answer.
I put my phone number also. Dr. Swati, you're feeling bad that you were not able to submit. Just send me a hello. I will send you the link. Or Nilima will send you the link. You can.
No, I think we should just tell the ICOG office to
Okay.
all those who have attended today, because the person who is managing the platform will have everybody's email IDs who have attended. The link should be sent to them and only they should be allowed, not who have registered, because there was so many registrations, but all have not attended.
Correct. 300 plus have attended today. Okay.
So I think we can log out now.
All right.
Thank you, ma'am. Thank you for the opportunity.
Again, congratulations for wonderful day one. Hope
Yes,
day two will
Dr.
be more
Minu,
interesting.
even I say, congratulations, Dr. Manish, you are really telling a correct thing. Wonderfully done today's program.
Yeah.
This is the first time I'm doing my ICOG FOGSI course, so I was really very stressed and I was very anxious about it. Last night I didn't sleep. I was talking to Srishti till 1 in the night that what is happening. But
And madam, that's why Susti is working up to 11:30 last night.
yes.
Sir, even ma'am, when she's anxious, she's so calm, she's so kind. Whenever she's talking, it doesn't feel like there's some tension going on. So that was a wonderful experience
So,
for me.
madam, all the Singh Rasi people doesn't have to roar. Madam is one of them. She is this kind lion or kind lioness.
Congratulations, Meenu ma'am. Very well done and very well conceptualized, and absolutely you've justified the entire ICOG program.
Thank you.
Very nice.
Who is Dr. Juhi Niyogi? डॉक्टर जूही नियोगी, प्लीज आपका वीडियो बंद करिएगा.
I think सर वो उनका फोटो है उस पे.
नहीं मैम, वो अभी हमने यहाँ से ब्लॉक किया, अदरवाइज वो वीडियो उनका शुरू था. और वो जो क्योंकि मैं अगर परमानेंटली ब्लॉक करूंगा फिर वो 3 दिन अटेंड नहीं कर पाएंगे.
Okay.
Thank you for that correction, ICOG team. We thank you for acknowledging the open video with open dressing.
And Madhuri madam, have you logged out already?
Yeah, madam
I
has.
think so. Madam cannot stay for such a long time. But all the talks were so engrossing that we couldn't leave the EA, even though we are doing some other work, but continuously hearing it. Dr. Minu, wonderfully done, really.
Dr. Supriya, thank you so much. Thank
And Srishti, I should appreciate you also.
Thank you.
And thank you to Manish sir for making it so lively throughout your comments, everything. So you made it very wonderful, the whole program.
Thank you, madam. Thank you.
So thank you so much.
Okay.
Sudha also joins.
Right.
We will be joining tomorrow. Also.
Yeah, madam.
Yes. Bye.
Thank you. Namaskar. Good night.
Good night. Good night.